Hi, David. Hi, Mitch. Naka-off yung mic mo, Mitch.
Hello, Doc.
Mitch, si Dr. Teresa Laico.
Hi.
Cebu. Mark. Hi, Mark.
Good evening, sir.
David is in, right? I think David is already in. So anyway, we're just waiting for the rest to come in. We're already online. We're just waiting for the other participants to also come in and log in. There may be in 10 minutes time. We'll start the program. Dr. Mendoza is also inside. Kuya Ike, magandang gabi. Teresa, Dr. Mendoza is our president for the Philippine Association of Laparoscopic and Endoscopic Surgeons. Kuya Ike. Hey, David.
Oh, wait. Hey, how are you?
Hey, good evening. Good evening, everyone. Kuya,
Okay.
good evening.
All right.
How are you, Ray? Hi, Mike. Hi, Simon.
Hi,
Good
David.
evening.
Good evening.
Hello, everybody.
Kuya Allen, thank you. Good evening, everyone. Hey,
Good.
Thank you, Kuya.
yes.
Nathan just texted. Nathan is dressing up. He's in the shower. It's 5:55 actually. Apparently, Nathan left Florida the other week and went home to Colombia. He's now in Colombia. So it's
okay.
yeah.
You
So
went
it's
for
gonna be
holiday.
it's gonna be 6 o'clock in the morning in Colombia.
Wow.
Yeah. Camilo is in Santiago now. He's logging in. He's just doing one procedure and then he's gonna log in a few minutes time. Hi, Dr. Palines. Dr. Palines is the chair of Batangas Medical Center. Anyway, we'll just wait for a few minutes, then we can all start. Kuya, thank you. Thank you for
Ay,
coming.
thank you, Kuya. Thank you.
Maganda yung program, no?
Maganda. Maganda, Kuya. I like it. Divided to three parts.
Yeah.
Very nice.
We divided actually the bariatric part. Michelle Limlu will explain it later. So three parts from perspective to procedure and then complication.
Complications. Very nice.
We're quite uh, we're quite lucky to have all the experts. David is here. Nathan, Camilo, Simon, Javid, I think is joining us in a while.
Mm-hmm.
So Pep, all the bariatric experts from Asia will be coming in.
Very good. Looking forward.
Hey, David,
Yes.
I saw the picture of Vito. Oh my God.
Where?
In Italy.
Oh, yeah, yeah. He's coming back. He's coming back.
Yeah.
He's coming back this Sunday.
We need to have another ceremony for him.
Oh, the one will be next year. Now, just to buy the bicycle, the new bike. Nothing much. He bought a new bicycle. That's very important. The rest is all relative.
That's true. Very true.
Yeah, yeah, yeah. No, I went there. It's okay. They are happy. They stay 1 month. They register the wedding. So I said it's okay. It's quite. Let them do.
That's just a registration for the wedding, right?
Yeah, yeah, yeah.
Oh, that's good.
They don't to register.
That's a
They
nice one.
want to register. That's all.
Yeah, although I was thinking it was a civil wedding or something.
No, 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 no. Just the registration at the municipal hall. They are registering at them. Yeah.
The next year we all go.
They are very happy. It's okay. At least the peace of mind.
Finally.
One small step done. So officially they are married. So okay. Then the party next year.
Yeah, very true.
Party will be next year. It's okay.
Let's all go to Bali and then Florence.
Yeah, but I told them, I don't know, today they were talking to open up. I think Singapore is going to open up soon with testing like Dubai, but only, not all the country. I think only the country they have a low infection rate.
Yeah, but the numbers in Indonesia are going up.
But still compared to 300 million, the number are very small. Mostly in Jakarta. So other parts are okay. For sure, they will open soon. I think next week, Batam, Bintan.
Yeah.
Yeah, I think a kind of like a domestic tourist. Simon, Hong Kong back to normal, right? Or school are still closed?
That initial seems okay, but recently we'll start to have another
Again?
silence. Some silence is in the medical area, seems still around. We open the bar and then it come out from the bar.
Actually, church and bar are the culprit. Party and the church.
Yeah, there are a few Thai lady that is a carrier, and then a group of men just get infected as well somehow.
Maybe my mojito.
In Korea, it's the church.
In Korea, it's the church. Yeah, everywhere. All the mosque, all the religious gathering.
Yeah.
It's okay. And people will learn. People will learn to live with this situation. Not no choice.
Good evening, Camilo.
The party man.
Hi,
Hey, party.
Camilo,
here.
the rest of these conferences, we don't have any.
You look refreshing.
The party boys.
Mr. Party Boy, Camilo.
I can't hear you, Camilo.
I think when you log in, the mic is off. Camilo's now okay?
Try again.
Camilo,
I think he log out.
Yeah, he tried to log in again.
log in
Yeah,
again.
the audio is off.
It's gonna be a very interesting night. We have this program, the Unified MIS Training Program, involving three hospitals, three government hospitals. So this is the conference for the fellows and the residents for the three hospitals, and we're actually sharing the conference to everyone. Uh, Apparently, the bariatric program has been endorsed by Dr. Ike, our president, palace president. So we're quite privileged and lucky.
Thank you, Kuya. Yes, it's a very good program actually, and we thank you very much for making Palace a part of it as well.
Thank you.
Thank you.
Let's just wait for Camilo. Nathan will be coming in a short while. He just texted. Is Dr. Woolbright already in?
Yes, he's in.
Yes, I'm in.
Hi.
Hi, Doc. How are you?
Hi, Dr. Woolbright. Dr. Woolbright, everybody was asking me from what state are we bringing you in? I said from the state of Cebu.
My family name is actually American, but I'm wholehearted Filipino. And I can speak straight Bisaya and Tagalog po.
Bisaya mo po.
Bisaya po ka. So fun to be
here. Coming in. He came in as a participant. Please accept him as a panelist. Also, Dr. Bobby Sarmiento. We're quite lucky to have all the luminaries of surgery in this webinar. In this, I'm quite lucky to have we're quite lucky to have friends like you guys, and thank you for joining us. Hey, Camilo, now we can talk.
Hi, is it okay now? Yeah.
Yeah, better. Is
microphone? It showed me some kind of fatal error, so I had to restart the computer. So I'll just do it right now. How are you?
Very
good
good.
Morning or good afternoon, good night.
It's good evening in Manila, and good morning in your area. It's 9 o'clock actually in Prague, Chile.
Is it today or is it yesterday in Manila?
It's the same day. AM in your area, PM in our area.
So you're living in the future.
Anyway, we're just waiting for, maybe we can start. It's already 7 o'clock, 7:05. Maybe we can start and then we'll just, Dr. Nathan Zundel will just come in a while. It's just 5 o'clock, I think 6 o'clock in the morning in Colombia. Apparently, Dr. Nathan Zundel came home from Florida to Colombia to see his family. So anyway, we would like to formally open this evening's webinar. Our webinar is all about bariatrics. It's divided into three parts. I think the Michelle Limlu, our bariatric team, Michelle, Dr. Mark Melendres, the bariatric group of the UMIST program will be introducing the program. Anyway, we're very lucky We have a very good friends coming over. We have Dr. Leiko, Dr. Karen Woolbright from Cebu coming in. And we have good friends, Dr. Camilo Bosa, my very good friend, my best friend, Dr. David Lamanto, Nathan Zundel, and of course, Simon Wang, a very good friend again, and of course, Nathan Zundel later on. We would like to thank Dr. Don Rosalia, the head of SIL, which is the, ano nga ibig sabihin ng SIL, boy?
Surgical endoscopy and minimally
Endoscopy and
minimally
laparoscopy
invasive.
group of Cebu. And Don is the program director of the SEAL program. Don, you're on mute. We developed the program exactly just for you guys. We would like to thank everyone for coming over. UMIST is the Unified Minimum Invasive Surgery Training Program of 3 government hospitals. Rizal Medical Center, of which Dr. Sarmiento is the chairman. Dr. Palidas is the chairman for Batangas Medical Center, and Dr. Abari for Quirino Medical Center. Anyway, without much further ado, let's start off with Dr. Ray Sarmiento, welcoming everyone to this for tonight's event. Dr. Ray?
Hello everybody. Good evening. Thank you for being here, and I think we have a very interesting night. We have so many guests, luminaries of bariatric surgery, and they come from all over. They will be introduced properly later by our moderators and our MCs. So I hope everybody will learn a lot tonight. So I welcome everybody to this UMIST bariatric series. And also, Simon saw me earlier with no hair. You might have to take a look at Don Rosello and see how much hair that he has right now. So everybody, welcome.
Thank you, Ray. So let's go to Dr. Abari, the chair of Quirino Medical Center, to welcome everyone. Dr. Abari.
Hello, good evening, everybody. Yeah, welcome to this first bariatrics surgery series, and we are so fortunate to have with us our local speakers and our international experts. So I think they would be introduced later on. So to the participants, especially to our palace president, Ike, for the welcome, and yeah, everything I think would be said. So it's back to you. Thank you, and enjoy the day. Enjoy the night. Thank you.
Thank you, Dr. Abari. And of course, we go to Dr. Palidas, the chair of Batangas Medical Center. Dr. Palidas.
Yeah, good evening, everyone, and welcome to this first of the three lecture series on bariatric surgery. I would like to acknowledge the presence of our palace president, Dr. Ike Mendoza, and our PSGS president, Dr. Bob Sarmiento. Thank you, mga sirs, for attending this sessions. And of course, I would like to thank our 5 speakers who will share their expertise on how to address this. Actually, it's also a pandemic, obesity, and it has affected more than what the coronavirus has affected worldwide, 2.1 billion individuals. So thank you to our 5 experts, Dr. Teresa Leiko, Dr. Karen Woolbright, of course, Professor David Lumanto, Professor Zunday, and Dr. Camilo Bosa from Chile. Thank you, and back to you, Allen.
Thank you, sir. Of course, before we start, I would like to call on the president of the Philippine Association of Laparoscopic and Endoscopic Surgeons, of which this program is actually endorsed by the society, I would like everyone to welcome Dr. Ike Mendoza, Miguel Mendoza, the president of PALIS. Kuya Ike.
Thank you very much, Kuya Allen, and good day to everyone. Thank you for your introduction. It's with great honor and privilege really to be invited to the SEAL UMIST Joint Webinar Conference. And on behalf of the officers and board of directors, fellows and associate members of the Philippine Association of Laparoscopic and Endoscopic Surgeons, please allow me to extend our congratulations to the trailblazers of the consortium of UMIST for coming up with these relevant weekly teleconferences that benefits a lot of surgeons in our land today. And I would like to congratulate Drs. Allen Buenafe and Dr. Ray Sarmiento, program directors of the UMIST program from Rizal Medical Center, as well as Dr. Alex Palines, the chair of the Department of Surgery of Batangas Medical Center. And also, of course, to my riding buddy, Dr. Omi Abari, chair of the Department of Surgery of Quirino Memorial Medical Center. I would also like to personally thank si Kuya Don Roselio, program director of the SEALS MIS Fellowship Program from Cebu, and also the designated course director for this three-part bariatric webinar series, together with Dr. Ray Sarmiento, for your personal invitation to be to invite PALES as an organization and the subcommittee on MIS on bariatric and metabolic surgery of PALES as well. It is indeed an honor to have PALES participate in this worthwhile endeavor. Welcome to all our friends, our international guest speakers. Thank you for joining us today. To all of you, of course, Professors Nathan Zundel, Professor David Lumanto, Professor Sutep from Thailand will be speaking later on in the next 2 to 3 weeks. Dr. Camilo Bosa from Chile. Camilo, hi. And of course, Dr. CK Wang later on, Mufi, Philip Gan, Ken Loy from Australia, Manuel Neto, Kasama from Japan, Jaideep, and our very own from the Philippines, Karen Woolbright, Teresa Leco, and Ray Sarmiento. Greetings also to Dr. Simon Wong from Hong Kong, and of course to our president of the Philippine Society of General Surgeons, Dr. Bobby Sarmiento. There's no question that as surgeons, all of us need to work together and collaborate into a multidisciplinary approach in helping those patients with obesity and as well as bariatric weight problems. Hence, with the guidance of our faculty, we look forward to sharing of experiences as well as knowledge and hopefully some skills in the performance of the surgeries during these next 3 weeks, today and succeeding 2 lecture webinars in the coming 2 weeks. Again, on behalf of PALES, I wish everyone a fruitful learning experience in today's educational webinar. Congratulations once again, Kuya Allen and Kuya Ray and Kuya Don Roselio for this truly excellent program on bariatric surgery. Maraming salamat po.
Thank you, Kuya Ike. And of course, we would like to call on Dr. Bobby Sarmiento, the president of the Philippine Society of General Surgeons, to give us a few words. Kuya Bobby.
Good evening, fellow surgeons. My pleasure to be part of this very exciting undertaking involving the surgery residents and the consultants of PSGS. Again, my congratulations to the organizers. You're making us proud. Thank you, and anticipating a very interesting program ahead.
Thank you, Kuya Bobby. And of course, before we start, we're quite lucky to have the president of the Asia Pacific Metabolic and Bariatric Surgery Group, the president, Dr. Simon Wong from Hong Kong. Simon?
Hi. Nice to be here today. Yeah, this is my great honor to be invited as a part of this activity, and I think the whole Asia or even Philippines and everywhere apart in the world will be benefit from this series of lectures. And on behalf of the Asia Pacific Metabolic and Bariatric Surgery Society too, I hope this education forum will be continue on in the next few months or years, and so everybody can still learn during this critical periods. And I'm looking forward for the great lecture. Thank you.
Thank you so much, Simon. So anyway, before we start, I'll give you off now to Dr. Don Roselio, the team of SEALS and UMIST, to Dr. Don Roselio and Mitch Limlu and Dr. Mark. Anyway, Don, so let's start off the program. Dr. Don Roselio, please.
Thank you. Hi, good evening to everybody. First of all, I would like to thank the staff in UMIST, of course, Dr. Alan Benefe, the program director, the chairman of the three different departments of surgery, Dr. Romy Abari, Dr. Ray Sarmiento, and of course, chairman of Batangas Regional Medical Center, Dr. Palines. It's been a great opportunity to be working with you. I would like to thank also and appreciate the presence of Dr. Ike Mendoza, our Palace President, Dr. Roberto Sarmiento, President of PSGS, and I would like to thank Simon Wong, Professor Simon Wong, for taking this invitation. Maybe in some other undertaking with regards to bariatric surgery, surgical endoscopy, or upper GI surgery, we could have this opportunity again to invite you to be one of the speakers next time. Thank you. To the speakers, two of the speakers are actually coming from Cebu. They're the flowers. Literally, because all of our speakers are, males, and these two lovely ladies will give us an opportunity to learn and give their insight and learn about their insights in internal medicine with regards to obesity and bariatric surgery. To all our foreign speakers, Professor Lumanto, Professor what else is here? Sorry. Professor Camilo Bosa. Thank you so much for taking time out to giving us a lot of your insights with regards to obesity. Thank you.
Thank you, Don.
Thank you.
So let's start off. Let's call on our moderators, Dr. Mitch.
Hello, good evening, everyone.
Right now. Thank you, Mitch.
Thank you everyone for joining us in this weekly teleconference on the bariatric series. I'd like to acknowledge all our foreign speakers and our panelists, and of course our organizers, heading the projects of the teleconferences, Dr. Buenafe, and the head of all the other involved hospitals. So we'll have a 3-part series. For this week, we'll be talking about the perspectives on bariatric surgery. And then after that, next week, we will be moving on to how to do each bariatric surgery, the essentials, mostly the major types of bariatric surgeries. And then after that, of course, when anyone does any type of procedure, any surgeon doing any type of procedure, it's also important for us to know that we should be able to anticipate any type of complications and also be able to manage these types of complications. So I think our lecture series, our topics will be very relevant and interesting to our audiences. So I hope everyone will join us in the 3-part series, and I hope everyone would enjoy it. Thank you. And to introduce our speakers, I will give the floor to my co-moderator, Dr. Mark Melendres.
Hello, good evening, everyone. Thank you for attending this first part of the lecture series in bariatric surgery by the UMIST group. So I will be introducing our panelists for tonight. We have a star-studded cast. So can someone share our slides? Okay, can we go back to the beginning? So our opening remarks was delivered by by Professor Simon Wong already. He's the current president of the Asia Pacific Metabolic and Bariatric Surgical Society, APMBSS, and the chairman of the Hong Kong Society of Metabolic and Bariatric Surgery. So our next speaker, is Dr. Teresa Leiko. She will be delivering a topic on medical management of obesity. She is an associate staff of the Department of Internal Medicine, Section of Endocrinology, CDUH, associate staff, Department of Internal Medicine, Section of Endocrinology in the University of Cebu Medical Center, and is a diplomate in the Philippine Society of Endocrinology, Diabetes and Metabolism. Okay, our next speaker is Dr. Karen Woolbright. She will be giving a lecture on the challenges in the medical management of obesity. She is a graduate associate staff of the Cebu Doctors University Hospital, associate staff of the Allegiant Regional Care Hospital. She is a member of several societies: Philippine Society for Parental and Enteral Nutrition, European Society for Clinical Nutrition and Metabolism, and American Society for Parenteral and Enteral Nutrition. Okay, so our next speaker, I think this one doesn't need that much. I think we all know who Professor David Lomanto is. He will be giving a topic on the Asian perspective on bariatric surgery. He is the past president of the Endoscopic and Laparoscopic Surgeons of Asia. He is the past president of the Asia Pacific Metabolic and Bariatric Surgery Society, past president of the Asia Pacific Hernia Society, is the current director of the Minimally Invasive Surgical Center of the National University Hospital of Singapore. Our next speaker is Professor Nathan Zundel. He will be giving a topic on the global perspective on bariatric surgery. He is the president of the International Federation of Societies of Endoscopic Surgeons. He is the past president of the International Federation for the Surgery of Obesity and Metabolic Disorders. He is the current president and governor of the American College of Surgeons South Florida chapter. And last but not least, our last speaker is Dr. Camilo Boza. His topic will be the bariatric and metabolic surgery in Latin America. He is a bariatric surgery specialist in the Pontificia Universidad Católica de Chile. He is the past president of the International Federation for the Surgery of Obesity and Metabolic Disorders, and is an associate professor of the Pontificia Universidad Católica de Chile. Okay, for our series of topics, it will be introduced by Dr. Michelle Limlu. She will also be introducing our panelists for tonight. I mean.
Okay, so for our topics this evening, I know that a lot of our audience are surgeons and are very interested in doing bariatric surgery themselves. However, I think it's also very important that even as surgeons, that we would understand why this is relevant, why bariatric surgery is actually very relevant these days, and especially during the pandemic of diabetes and then overpowered by the pandemic of the COVID, which makes it even more important because as we know that obese patients are actually more affected heavily by this pandemic. So without further ado, our topic for tonight is going to be all about the medical impact, the challenges of managing obesity, and also how other countries around the world have managed to incorporate bariatric surgery into the daily practice of medical care in our patients. So let's start with Dr. Teresa Leiko in talking about the medical management of obesity.
Hi, good day and good morning to everyone. Let me just share my slides first. Okay, can I just get a confirmation if what you see is just my slides, right? Correct?
It's,
Yes, we can see your slide.
I think it's the presenter view.
Yeah.
You don't see any notes, correct? Is that right?
Yes, your notes.
No,
You can actually see your notes.
you can see your notes.
Yeah, we can see your notes.
I'll just make some changes, sorry. Okay, this is just purely the slides, correct?
Correct.
Okay, sorry about that. Okay, so this will be my topic for tonight. Okay, this is just my disclosure. Okay, just give me a minute. Sorry. Okay. During prehistoric times, the burden of disease was that of pestilence and famine. In the 18th century, with the advancement of technology and especially in the field of agriculture, food supply became readily available. The initial effect of these advancements led to increased longevity, increased body size, and overall improved public health. With further progress, the increase in food availability was paired with the reduced activity. This has led to obesity in the centuries that followed. In 1997, the WHO declared an obesity epidemic. In 2013, the American Medical Association labeled obesity as a chronic disease that, if untreated, can lead to various other health problems and burden the public healthcare system. The incidence of obesity continues to rise, be it on a global scale and even here at home. As a matter of perspective, the prevalence of obesity in the Philippines doubled in 20 years. Currently, 1 in every 3 adult Filipinos are either overweight or obese. In responding to this alarm, medical societies formulated clinical practice guidelines or CPGs. I have condensed the various recommendations, but majority of the points I'll be emphasizing are from the 2016 AACE CPG for medical management of obesity and the 2019 CPG for the perioperative nutrition, metabolic, and non-surgical support of patients undergoing bariatric procedures formulated by the various medical societies. At the end of this talk, I hope that you, the audience, will be fully confident on assessing and evaluating an obese patient, be knowledgeable about the different treatment modalities for obesity, and be familiar with the role of each member of the medical team taking care of the obese patient. The first question we should answer is whether the patient is overweight or obese. Obesity is the accumulation of excess body fat that poses a health risk to an individual. The body mass index is the most widely used index to classify obesity because of its convenience and several studies supporting its association with morbidity and mortality. Those with a BMI of 25 to 29.9 are considered overweight, whereas those with a BMI of 30 or above are classified as obese. For Asians, the cutoffs are slightly lower owing to the fact that Asians have a greater volume of visceral fat and are at higher risk for obesity-related complications or ORCs at a lower BMI compared to their Caucasian counterparts. The BMI, however, is fraught with limitations. It is unable to discriminate between fat mass and fat-free mass.
Hey, Alan, how are you?
It can identify the patient's
I'm sorry?
amount of fat.
Okay, what time? Who is next?
And it is not reflective of body shape.
Okay.
Using BMI, individuals with high muscle mass
and then
correctly be classified as obese. Waist-hip ratio and waist circumference were found to have better correlation with body fat. Asian men with a waist circumference of at least 90 centimeters and Asian women with a waist circumference of at least 80 centimeters have increased cardiometabolic risk. The guidelines recommend to measure the waist circumference in those with a BMI of less than 35 to get a better assessment of body adiposity. For better delineation of fat distribution, several non-invasive imaging modalities may be used. However, clinical utility of these measures is limited by availability, cost, and lack of outcomes data for validated cutoff points. The next step is to evaluate for possible weight-related complications and coexisting hormonal disorders by obtaining a comprehensive medical history and physical examination. ORCs include prediabetes, metabolic syndrome, type 2 DM, dyslipidemia, hypertension, cardiovascular disease, non-alcoholic fatty liver disease, polycystic ovary syndrome, female infertility, male hypogonadism, obstructive sleep apnea, asthma, urinary stress incontinence, osteoarthritis, gastroesophageal reflux disease, and depression. Aside from asking about the patient's comorbidities and drug history, the patient should also be asked about life events that coincided with weight gain, the extent of physical activity, and food intake. Psychological assessment is essential as well, and so is asking the patient about goals and expectation, motivation, social support, psychiatric status, and the presence of stressful life circumstances. Some of the necessary laboratory tests to obtain include FBS, HbA1c, lipid panel, liver function test, ultrasound, 2D echo, and stress testing. For most ORCs, PE and review of systems will suffice, however. Some ancillary tests might be necessary to fully assess the condition. It is recommended that all obese patients be screened for hypothyroidism by checking the TSH. For most endocrine disorders, however, screening tests are only indicated if there is clinical suspicion. Secondary hypertension should be ruled out in obese patients with therapy-resistant hypertension. All obesity treatment guidelines emphasize the benefits of losing excess weight. The earlier guidelines, however, were considered to be BMI-centric, in that the patient's BMI determines the appropriate treatment. The more recent guidelines have now focused on the prevention and treatment of complications. They stress that the principal outcome and therapeutic target in the treatment of obesity should be to improve the health of the patient by preventing or treating ORCs using weight loss. Hence, different stages of obesity were described. Patients are classified based on their BMI and the presence of ORCs. Overweight individuals are those with a BMI between 25 to 29.9, but no comorbidities, whereas patients belonging to obesity stage 0 are those without comorbidities as well, but BMI is 30 or over. For these two cohorts of patients, treatment is generally secondary prevention. That means the goal is for the patient not to acquire any obesity-related disease. Obesity stage 1 are those with at least one mild or moderate comorbidity. On the other hand, patients belong to obesity stage 2 if they have one or more severe comorbidity. The treatment goal is tertiary prevention and therefore improvement of symptoms and quality of life. The Edmonton obesity staging system may be used to specify what qualifies as mild, moderate, or severe comorbidity. It uses several parameters to identify the degree of severity. In treating overweight and obese patients, before you offer bariatric surgery or even pharmacotherapy, the first and foremost action that needs to be done is to engage all these patients in a lifestyle therapy that will promote weight loss. The dietitian and health educator play an important role in the formulation of a meal plan. Patients are advised to have a low-calorie diet, providing 500 to 700 kilocalorie deficit daily. The guidelines did not recommend one specific diet over the other. An exercise trainer or physical therapist and occupational therapist must conceptualize a physical exercise program that is achievable for the patient. Aerobic exercise to at most 150 minutes per week and resistance training for 2 to 3 times per week is recommended. The health educator should have a thorough discussion with the patient on health, weight loss goals, stress reduction. Psychological evaluation and counseling are important in the mental preparation of the patient for his weight loss journey. Anti-obesity medications are given to those with ORCs. Those who are overweight or obese patients without an ORC can also be given these meds as an adjunct to lifestyle therapy if they either fail to lose weight or they regain weight. In the older BMI-centric guidelines, it is recommended to start anti-obesity medications if the BMI is at least 27 or in Asians at least 25. For patients with comorbidities, it is best to optimize weight loss by choosing weight-neutral drugs or those which are known to cause weight loss. Like in the case of diabetes, then it's best to use metformin, GLP-1 receptor agonist, SGLT2 inhibitors, or DPP-4 inhibitors. The patient's response to the anti-obesity agents must be evaluated after 3 months. It is recommended to stop the drug or change to another one if weight loss is less than 5%. The US FDA approved 4 anti-obesity drugs. It used to be 5, but lorcaserin, the serotonin receptor agonist, was recently removed from the list due to reports that it increases the risk of cancer and cancer-related death. Orlistat works by blocking the absorption of fat. Common side effects are GI disturbances such as abdominal pain, fecal urgency, and flatulence. Liraglutide, the only injectable agent in this group, is a GLP-1 receptor agonist. So it's a drug used in diabetes, but it also promotes early satiety and slows gastric emptying. Common side effects are nausea and vomiting. Kismia is a combination drug of phentermine, which is an anorectic agent, and topiramate, an anticonvulsant associated with weight loss. Because phentermine is a symptomatic, common side effects include BP elevation, tachycardia, constipation, insomnia, and paresthesia. Bupropion is a norepinephrine and dopamine reuptake inhibitor that has an anorectic effect, and it is combined with naltrexone, which potentiates the anorexia. Common side effects are nausea, headache, insomnia, and increased blood pressure. The last option in obesity management is bariatric surgery. Although some may perceive this as a drastic measure, there are many benefits of bariatric surgery. Firstly, it results in significant durable weight loss. So this was a single center RCT that compared diabetic patients who underwent bariatric surgery versus those who did not. And you can see the profound weight loss in those who underwent surgery, and this weight loss was still evident up to 5 years. In the same study, diabetes remission was seen at 2 years and 5 years post-bariatric surgery. The Swedish obese subject study showed that bariatric surgery resulted in significantly lower incidence of microvascular and macrovascular diabetic complications in the long term. Bariatric surgery patients also had significantly lower mortality as seen in this prospective controlled study. Additional benefits of bariatric surgery are improvement of BP, hyperlipidemia, and OSA. All guidelines are unanimous in recommending bariatric surgery for those with a BMI of 40 or above, and those with a BMI of 35 or higher, and with at least one severe or ORC. ADA even recommends this procedure to poorly controlled diabetics with a BMI of at least 30. Most guidelines also recognize the different BMI cutoff per ethnicity and suggest that this may be used as basis. In that case, for Asians, indication for bariatric surgery starts at 27.5 for as long as they are diabetic as well. The caveat for these last two statements, though, is that the level of evidence is not as robust as the previous recommendations. Bariatric surgeries are divided into two based on their mechanism of inducing weight loss and other metabolic changes. The restrictive type limits the capacity of the stomach. So examples are the adjustable gastric band and the sleeve gastrectomy. On the other hand, the non-absorptive type limits the absorption of pancreatic diversion induced laparoscopic bariatric surgery. Factors such as the surgeon's expertise with a particular method and the presence of a competent multidisciplinary team is essential. The patient may also be asked about which bariatric surgery he or she prefers. And lastly, the patient and the medical team must agree on a shared goal in terms of degree of weight loss and improvement of comorbidities they want to achieve. This table details the target weight loss, favorable and unfavorable aspects for each bariatric procedure. Briefly, the BPD followed by the Roux-en-Y results in the greatest weight loss and beneficial effects. However, they are much prone to nutritional deficiencies. The sleeve gastrectomy is easy to perform and has fewer long-term complications, but leaks are common. LAGB offers the advantage that there is no anatomic alteration, but then complications such as erosion, slip, or prolapse are possible. As you may have realized, It takes a village in caring for an obese patient, especially if surgical treatment is considered. The core team providing such care should optimally consist of the following specialists experienced in obesity management and bariatric surgery. In getting the consent, the patient must be fully informed of the benefits, risks, and limitations of the procedure, even the volume of bariatric surgery the surgeon has done, and the extent of insurance coverage. Aside from getting routine pre-op labs, the physician must ensure that BP is adequately controlled and that diabetics must achieve good glycemic control. A full cardiopulmonary evaluation must also be done. Female patients of reproductive age must also be advised to avoid pregnancy prior to surgery and 12 to 18 months post-op. If they do get pregnant post-op, she must be monitored for nutritional deficiencies, and if they have a gastric band, it must be adjusted periodically to allow the necessary weight gain in pregnancy. Those taking estrogen or OCP must be told to discontinue this medication to decrease the risk of thrombotic complications. A dietitian must explain to the patient the dietary changes required after surgery. Most medical societies recommend that patients achieve a certain degree of weight loss pre-op, since this is associated with post-op weight loss as well, and in terms of the actual surgery, this can help the surgeon since the liver volume will be reduced. This can be achieved by having a low-calorie or very low-calorie diet for 2 to 4 weeks pre-op, supervised by the dietitian. Patient is also advised to stop smoking. A thorough psychological or psychiatric evaluation is an important step in the preparation of the patient for surgery. The anesthesiologist must be familiar with the enhanced recovery after surgery pathway for bariatric surgery. ERAS pathways aim to maintain physiological function, enhance mobilization, reduce pain, and facilitate early oral nutrition post-operatively by reducing perioperative surgical stress. ERAS involves the use of multimodal pre-anesthesia meds, avoidance of excess fluid administration, post-operative nausea and vomiting prophylaxis, early ambulation, DVT prophylaxis, and control of blood glucose with continuous IV insulin. Common surgical complications of bariatric surgery include gastric band erosion, infection in the ring or port, gastric pouch perforation, fistula formation, bleeding, anastomotic leaks, and small bowel obstruction. Common medical complications include thromboembolism, respiratory or cardiovascular failure, cerebral ischemia, rhabdomyolysis, and acute renal failure. Once post-op, staged meal progression must be supervised by the dietitian. This consists of clear liquids for the first week, followed by general liquids and purees in the second and third week, and eventually progressing to mechanically soft food with patient being advised to chew slowly and have small portions. Calcium, vitamin D, and vitamin B12 supplementation must be given. Common surgical complications of bariatric surgery. Long-term complications include vitamin and mineral deficiencies, cholelithiasis, dumping syndrome, hypoglycemia, osteoporosis, weight regain, and depression or anxiety. The follow-up intervals differ based on the type of surgery done. During every follow-up visit, the team must monitor the trend of patient's weight loss and adherence to physical activity recommendations. Laboratory tests should include those needed for monitoring of nutritional deficiencies. Finally, once the patient's weight has stabilized, body contouring surgery may be considered. The following are the main points of this talk. Complete assessment for obesity involves 2 steps. Number 1, measurement of BMI and other parameters known to have a correlation with cardiometabolic risk, and evaluation of patient's comorbidities. Treatment of obesity is likened to an inverted pyramid, wherein lifestyle therapy is an essential primary step, followed by medical therapy and bariatric surgery. Finally, lifelong focus and dedication on the part of the patient and the entire medical team is necessary to fully realize the benefits of bariatric surgery. And with that, thank you.
Thank you so much, Dr. Aleco, for your very comprehensive introduction in the medical management for bariatric surgery patients. So I think it's very relevant that our audience would also be aware that bariatric surgery is not just an end-all solution to obesity, but it's just an add-on to other treatment modalities that we have available that must be offered and must be implemented for our obese patients. So thank you so much for a very comprehensive lecture. And before we move on to the next speaker, I'd like to acknowledge the presence of Professor Nathan Zundel. He is the president of the International Federation of Societies of Endoscopic Surgeons. He's the past president of the International Federation for the Surgery of Obesity and Metabolic Disorders. And he's the president and governor of the American College of Surgeons of the South Florida chapter. Welcome to our conference or to our teleconference, Professor Nathan Zundel.
Hi, Nathan.
Hi, thank you for the invitation, guys.
Also, I'd like to remind our audience to reserve all your questions for our open forum, and be sure to list them down because you will probably be having a lot more questions after the lectures of the following speakers. And we also have our panelists who will be more than happy to answer your questions. We have Dr. Sutep from Thailand, and Dr. Kasama. Is Dr. Kasama here?
We have Dr. Kasama now. Katsu, hello, good evening.
And of course, we have our very own Dr. Don Rosello, and we have Dr. Florence Gan. She's another flower in the obesity field. She just recently finished her subspecialty training in obesity medicine from Taiwan under Dr. Chikun Huang. So I'm sure they will be more than happy to answer any questions regarding our topics for our series part 1. So for our next speaker, she will be talking about the challenges in the medical management of obesity, because even though that we have a very high obesity rate in the Philippines, I think more at around 40% already, they are still very reluctant at the idea of having to undergo bariatric surgery. So for our medical friends our friends in the internal medicine department and other fields, it's also it would be nice to have a perspective from their part in managing these patients when they refuse surgery at the time of when it's already indicated. So we have Dr. Karen Woolbright. You can have the floor.
Thank you very much for the introduction again. I'm going to share my slides now. Okay, so good evening, everyone, and good morning as well to the other side of the globe. It's a privilege to be here today, and I'm humbled by these speakers. Obesity is challenging to overcome, even with all the available therapeutic interventions. So I'm here as a clinical nutrition physician. I'd like to expound on the many hindrances in the medical management of obesity. Now, I'll keep it short and very straight to the point. So what is obesity? When I start my presentations, I usually start with some definition of terms. So obesity is a condition based on the BMI classification of a person. So it's standardized by the equation of mass in kilograms divided by the square of the height in meters. I think we all know this. This classification is not just to see if you're a big or a small person. So obesity has been shown to have a higher risk of comorbidities such as diabetes, hypertension, heart disease, etc. That's why obesity is not just for size. And obesity also is not a permanent condition. And that is why we're here today, to know how we can change that. What is the equation of the BMI? So the mass of the patient, which is taken in kilograms, is divided by squaring the height, which is in meters squared. So the squaring makes sure that the body dimensions remain the same in different weights. So that is what is the disadvantage though of the BMI is that it does not include body composition. So you may have a very high BMI, but you can you might not be obese in fat. For example, if you are a John Cena obese or a Jack Black obese, so both of them could be obese. Now, this does not show the fat or muscle in the body. So what is more important also is the ascites. For us internists, ascites and edema could present with edema in a patient. So it is very misleading. That's why it is only used really for initial assessment. Now let's start with dissecting our objectives for this lecture. First, we need to know why weight reduction is important. What are the goals that patients have, why they undergo weight reduction? And then we'll make a very short roster of medical managements available. This was already taken by Dr. Leco, so I'll just be brief on this. But after that, I'll enumerate the challenges that medical management has in regards to weight loss. So this is my favorite. So why do people want to lose weight? So usually it's aesthetic, or it could be for health reasons. Now, here are some of the reasons we know. So first is our impulse to blend in, and so we want physical change. We want not to stand out as much. So here, many people just want to make sure that they're about the same size as everyone else. So it's your body image. How do you look with regards to everyone around you? And others, on the other hand, the reason why they want to lose weight is they want to fit in to a certain high standard upper cut in terms of being healthy. Other reasons for physical change to lose weight would be for employment, such as if you're a flight stewardess, or you want to be an actor or an actress. So some people, they want to lose weight because they want to fit a certain size of clothes, of a certain size of clothes. So sometimes they just want to fit a size 2, or they want to be toned. So you want to be toned because you have probably a slip disc or joint and knee problems because of your weight. So you need to tone your quadriceps muscles or the back muscles, or maybe you want to decrease your exercise, increase your exercise tolerance rather. Another is for strength building. So to develop lean body mass. Some of these obese people have poor functional capacity, thus they opt to lose weight to have increased functional capacity. Another reason, another goal for these patients to lose weight is to change the shape of their body. So they want to get 6 packs, or they want to have buttocks enhanced by exercise. And so for men, it is the upper body build up, or the biceps or the traps. And yet there's still another reason that's more important, and this is for overall health. Most of my patients decide on weight loss because of a startling laboratory result, or a recent visit to the emergency room for symptoms such as headache with an initial diagnosis of hypertension in a young patient, or maybe a sudden diagnosis of diabetes, or a stroke in the young, or chest pain that leads to myocardial infarction. So these comorbidities are one of the reasons why a lot of my patients actually show up to ask for weight loss medically. another reason why they want to lose weight is because they want to increase their life expectancy. So study shows that life expectancy actually has conflicting randomized clinical trials, not conflicting studies on whether they increase lifespan or not. But the reason why the studies are conflicting is because the weight loss could depend on whether it was intentional weight loss or unintentional secondary to a malignancy. And if the process was actually a fast weight loss, or the process was too fast, and so it causes iatrogenic malnutrition in the process, so such as in anorexics. So before you believe the reasons why life expectancy can actually be decreased with weight loss, you have to dissect the research that it was done. So for medical management of weight loss, the pillars of these medical management center on diet, exercise, and currently medications. There are other new novel therapeutic management that are not surgical, but they are still not yet very common. Now, in dietary management, the primary management of weight, a proper dietary plan should be made by a dietitian. They're the experts who can make sure that the patient's intake in and out of the day is really managed properly. Now, weight loss is dependent on this adherence to the diet. It actually does not matter what type of diet that you have for your patient. It is based on caloric delivery, day in and day out quantity to produce a deficit. Eventually, it's not the type of diet, but the deficit. So another thing we have to consider with regards to medical management of dietary, of using diet for weight loss is the team approach. It is very important that the patient, the family, and his friends, and a multidisciplinary team, including endocrinologists, cardiologists, even psychiatrists for the management of his depression and compliance to the diet is important. Early on, knowing that medical management of obesity is not very successful, early on, a surgeon should already be involved in the medical management so that there is a goal and a plan, since more than half of the time, dietary management to treat obesity fails. So over 8%, only 8% of diets actually are successful, whether it is any of these diets mentioned here, up to the recent diets that such as intermittent fasting. However, after this success, you can always expect another 50% rebound to weight gain. Why is this so? Because they stop the diet that causes them to have that 8% success rate. And so usually the diets start with weight loss, they fail, they rebound, they go to the next diet. This is what happens to most of my patients. They try what is the most common diet in the internet, what their friends do. The next pillar in medical management for weight loss and obesity is exercise. Now, it is the most difficult to sustain among the obese. And why is that? Because it lacks consistency. When you are morbidly obese, a simple exercise would be exhausting. And so the fatigue and the extra weight during exercise is frustrating. Sometimes exercise is also misunderstood as just having to walk every day. But it needs actually to produce a habit to continue the decrease in total energy expenditure. You need to make sure that there is a balance. And so you have to decrease the intake with the diet, and you have to increase the exercise. So this is very difficult, and it must only work together with the proper diet as well. Now, medications are usually given after about 2 weeks of diet and exercise, wherein you already see the patient start to have an initiative to the weight loss. Now, we have orlistat, which inhibits gastric and pancreatic lipases, so the fats are excreted unchanged. You have liraglutide, the glucagon-like peptide injectable appetite suppressant. And you also have phentermine, which is an adrenergic agonist. So it releases norepinephrine and thus produces lack of appetite. You have these other medications as well. Most of them are not available in the Philippines except for the first 3 that I mentioned. On top of that, we have to understand why is it challenging for them to have medication on top of diet and exercise is the cost of these medications. Now, this is a monthly estimate of the price here in the Philippines. This is Philippine price. I know this is an international conference, so you divide this by 50 to make $1. The orlistat would produce, the patient would spend approximately 4,500 pesos and will produce about 11% weight loss. So this is this is the percent weight loss in the first year and a half of treatment. For liraglutide, it is about 5% weight loss with an expense of around 20,000 pesos a month. Phentermine, about 10,000 pesos a month, would produce about 8% weight loss. So other medical managements that are not yet available would be transcranial magnetic stimulation. So it's also questionable. Hypnosis, though, has some success rates with, but only around 2 kilograms in around 1.5 years. Another novel innovation that can also show promise is the fecal transplantation using gut microbiome. But all of these medical managements are still more of needing randomized clinical trials. Now, the challenges for medical management involve the challenges for the patient, the healthcare provider, and the socio-cultural milieu that this patient has. So we have patient factors. Let's start with patient factors. So you have physical challenges, emotional challenges, economic challenges, the presence of comorbidities, and the compliance of the patient, and self-therapy. So physically, patients have a difficult time trying to lose weight when they are obese because of skeletal problems such as injuries directly related to obesity. They have already bad knees at the onset, and so asking them to do a lot of exercise that involves high impact exercises will most likely probably not be complied. They also have back problems, and so most of these patients will refuse exercise because of this pain. Another problem, another challenge is because most of our obese patients, although they are huge, they actually have a very small amount of muscle mass. And so this sarcopenic obesity, as you would call it, would actually mean that they are less tolerant to exercise and they have more asthenia because of the sarcopenia. They have poor exercise tolerance. On top of that, they have cardiac deconditioning because they have poor cardiac circulation on top of not being able to exercise regularly. Now, another challenge why obese individuals cannot sustain the weight loss is because of depression and rebound consumption of food items. So the moment they see that there is a rebound increase in weight, these patients will again consume the amount of food that they used to consume and thus regain all the weight that they lost before. Another emotional problem that is a hindrance to medical management of obesity is a lack of motivation. These patients have a very poor body image of themselves, so they have issues. And so when they go to the gym or when they show effort to decrease their intake, they are actually judged. And so they have a lot of anxiety together with the depression. Here in the Philippines as well, economic challenges to medical management of obesity is very common. The obese individuals usually have weight issues that prevent them from performing regular work. It's an effort for them to do regular work. And on top of that, their comorbidities are very costly. Here in the Philippines, we have to spend, the patients do not have insurance from the government for outpatient medications. So that has to come out of pocket. And so on top of this, they have to try to find healthier food options, and their socioeconomic class will means that they have to purchase lower cost foods that are more refined but fit their budget. And so it's in these times, it's very sad that a burger is actually cheaper than a healthier salad. Another reason why it's very difficult to lose weight among obese patients is because it's difficult to control their symptoms during the diet and exercise. So most of them are diabetic, they're hypertensive. And so you have the hypoglycemic episodes during the dieting, you have the increase in blood pressure because of the exercise. And so it causes inadvertent malnutrition as well when the patient tries to diet and then they still continue to drink their medication. And so we have a lot of expenses, a lot of comorbidities, and these patients here in the Philippines have difficulty. Another challenge for weight loss is compliance. So sometimes this is one of the things that we lack, are support groups. You have to understand that obese individuals, they need regular follow-up, and because they need to understand that rebound weight gain is also part of the process. And most of the time, they have no one to talk to and they don't have motivation. And so they always go back to where they started and they cannot sustain the weight loss. Most of these individuals, these obese patients, also start out trying to fix themselves first. So they go to the internet and research on different websites, and basically they get diets directly from the internet, and the inconsistent results will lead to frustrations, and then they will shift to another diet. Most of the time, before they arrive at the clinic, they have tried at least 2 or 3 diets, they have failed, and they have gained more weight in the process. Another challenge are the healthcare factors. Believe it or not, it is not just the patient, and it's not just the patient that causes the medical management to fail. The first failure is actually communication gap with the physician and the patient. Now, goal setting is very important for the patients. Why is that? Because they expect that the weight loss will be in a month or 2. It will actually surprise these patients when you tell them that the medical management will take them 2 to 3 years before they achieve their weight. And so if you don't tell them this, they will expect that you failed in the medical management of their obesity. And so they expect that they will lose weight fast. And so because you don't give them the timeline and there's a communication gap, these patients will not follow up. Another difficulty are the medication side effects. Now, we mentioned some of the medications that you can use in obesity, and most of them would have side effects on the gastrointestinal tract to produce decrease in appetite, and they will have bloating. Some of them will cause diarrhea, flatulence, and dyspepsia. The first one, orlistat, even causes fecal incontinence, and which is actually on oily fecal incontinence. So it's not very, the patient will not comply because of these things. Another thing we need to make sure that as healthcare professionals is to make sure that the patient must be monitored accurately. Sometimes it is also the mistake of the healthcare professional by giving a wrong energy expenditure or total caloric requirement to the patient by just estimating based on the weight. So we need to make sure that their energy requirements match with indirect calorimetry, and that their body composition also match with the goals during weight loss. Sometimes we have we fail to check that most of the weight gain came from fluids and muscle increase in muscle mass rather than weight loss. And so the inaccurate monitoring of these patients will actually give you wrong, will actually give them wrong caloric requirements. So you can actually increase or decrease further the calories because the total energy expenditure and the body composition were wrong. So we also need to make sure as healthcare professionals here when doing a medical management of obese patients that at the beginning of the therapy, we have to already get everyone involved. So we need to get already the dietitians, the physical therapists, the specialists such as the endocrinologists and cardiologists for cardiac monitoring, and as well as the surgeons. Why do we need to get everyone involved? Because it will make sure that there is better follow-up, especially when the patient notices that everyone is involved. So you need to have a full team involved. And this is one of the biggest challenges we can have because not everyone is communicating. So sometimes the patient will have day in and day out of incomplete therapy. And so this will lead to goals that are not met. The next is the social cultural factors, which are challenging in the medical management of obesity. Now, recently Body Trends, just Big is Beautiful and You Deserve It, have allowed more acceptance of obesity, seeing it as beautiful, and many have misconceptions that fat can indeed be healthy. In fact, body image issues can be one of the hindrances to starting weight loss, even among physicians. Another hindrance socioeconomically would be convenience. In fact, being a modern society, as one of its disadvantages would be the online market, where you can just order anything online and then you can have a fast food easily, and you can get all the trendy food items that are high in calories. Another problem socioeconomically is that we, especially for most obese patients, are in the urban area, is that we move less. Transportation is very convenient. We take the elevator and the escalator to very near places, and there's always a comfortable waiting lounge. And this is another challenge now with the COVID pandemic, is that people stay home more in front of their computer and sitting down. So I expect a rise in the obesity in the next few months. My patients are actually not doing well. My obese patients managed medically are not doing well right now. You can imagine our success in decreasing their weight, and then all of a sudden, in the past 6 months, you would see the increase in weight because of this. So another problem for medical management in obesity is the culture. Now, in Asian cultures, especially here in the Philippines, weight is actually weight is not shunned so much, because wealth is what do you call this? Weight is actually associated with wealth. So it's very Chinese, and it's actually almost like we actually greet each other saying that, you gain weight, and Filipinos don't actually get insulted by that. That's actually something funny. And so because there's no stigma, not so much stigma against weight when it comes to increasing weight, that's why culturally in the Philippines, we're starting to have this problem. Another cultural problem is that the family ties are very close. And so eating in the same table with the same food every day in a family style manner. So we don't eat a la carte, we don't have our own plates. So the food is in the center of the table. And so this is a challenge for us culturally when we ask our patients to lose weight, because they cannot set aside their own plate. They have to stick to the family and then eat together with the same meal as the family. So in the medical management of obesity, first step is to identify that the patient is obese. Make sure that we have goal settings in a multidisciplinary team. So in summary, I hope you have learned something today, that the goals of weight reduction are improved overall health. And among the current medical management of obesity available, there are challenges that have to be overcome if medical management is the first option prior to bariatric surgery. So many times we advocate medical management in disease, but unfortunately for now, obesity has not yet been successfully managed in this endeavor. So as you can see, it's very disappointing how medical management can be. It's very tedious, and I hope that we can both help each other in managing our obese patients. Thank you very much.
Thank you, Dr. Wilbright. That was a very interesting slideshow that you had shared with us, especially that you made an emphasis on regarding the cultural issues, the socioeconomic factors, and family ties, very important, and the effect of traditional practices in our country. So, but since we're running a little short on time, as much as I would like to discuss more with you and pick your brain about our issues in the medical challenges, I think we have to move on to the next speaker, and I'll give the introduction to Dr. Mark Melendres.
Okay, thank you, Mitch. Again, thank you, Dr. Wilbright, for that very informative lecture. I think a good take-home message from that lecture is that surgeons should also be involved in the management of obesity, regardless of whether medical management will be undertaken first, because that's really not the case most of the time. And that medical or non-surgical management provides relatively low long-term control of obesity because of several challenges, as you said. So anyway, our next set of lectures will be focusing more on the surgical management of obesity and its complications. For physicians or even surgeons not yet well versed in bariatric and metabolic surgery, you might be interested to know that the indications for bariatric and metabolic surgery actually differs between Asians and Caucasians. So to give us a lecture on the Asian perspective in bariatric surgery, may I please welcome Professor David Lumato.
Hello, can you hear me?
Yes, we can hear you.
Yes.
Okay, wonderful. Thank you. Good evening. Thanks, Alan and Ray and Don for organizing such a inclusive conference. I'm sure that will be useful for the resident, and we will open a new onset, maybe because obesity become a common practice today. Alan asked me to talk about the Asian perspective, and I will show some briefly. I hope we don't take so much time. What will be, what is the obesity in Asia? What are the implications that we do have with some number? I was just listening, but I was also playing with my phone. And I remember when 7 years ago, I was with Alan in Himalaya for some education, and we were actually, Alan was sleeping while I climbed to see the Dhaulagiri, beautiful 8,000 meters. Alan, remember? In Poon Hill, you was there. Look, it was a beautiful time. Now we are in different situation. And I think the previous two speakers show how obesity is a pandemic and they pose a very major risk worldwide with the billion of people. But the most tremendous thing is that the obesity is growing in the developing country. Usually obesity is a disease of developed country and in the poor people. In Asia, we have different. The people are obese are the rich people, not the poor, because they have access to more food. It's a bit different. And there is such a big problem in Asia that is very difficult to ignore, especially because obesity in Asia have a major problem affect with the metabolic syndrome, more people, and especially with the complication and side effect. We'll see how this number coming from WHO, I see how mostly the economy that are in transition, like Philippines, like Indonesia, like Malaysia, Thailand, are the one more affected by obesity. And also the developing market country also are the same compared to developing country itself. Mostly so the economy are in transition, not the proper poor country. Is one of the Asia is one of the highest continent in the world with the developing country and economy in transition compared to other parts of the world. You can see in this graphic where we have a more rural area, and in Asia is the highest developing country rate. Why is this happening? Because I think there is a double effect of increasing consumption of energy. I think the two previous speakers, Lakon and Woolbridge, already pointed out that so overeating high saturated fat imply a consequent obesity together with the reduced physical activity. I'm sure in Philippines, in Singapore, Indonesia, all over Asia, because of also the weather, people try to live in a mall and park close to the escalator more than walking, as happened in maybe in the Western country. But also there was a change in the nutritional status. They start from the children, especially in the 50, in the 60, when the economy start to implode a bit more. And there was especially in India, there was Gandhi start this school supplementation program, so the kids can go to school and get a free food, so more poor people can access the food. And there was a change in the status of the kids. On the other side, there is also, I think most of you ladies know that there's an Asian obsession. I think if you heard a few years ago about the A4 waistline, that was one of the hot topic in China and in Korea, where from one excess we were to another excess, but show how Asia women especially are more concerned about the waistline and the weight than other countries. So Asia got fat, and you can see the percentage, the incidence of the number here. And you can see the number are really overweight. Not all obese are tremendous. 1/3, 1/4 of the population is overweight. But the most dramatic things that the incidence in pediatric patient is much higher in adult. I make an example. In Singapore, the obesity is 9%, or among the adult, but in the pediatric patients, about 16%. And most are single child kids in a family that are over pampered about food and overnutrition. More access to all the chain of fast food, of high calorie food, and so on. So it's rapidly growing everywhere. And you will see the number, how in Asia, in Indonesia, we see have 12% of the population. We are talking about 300 million population. So the 10% is a huge number. It's not the 10% of Singapore where you have 5 million population. It also increased the risk for future adult obesity. So if the child has obesity, this will exponentially bring more obesity among the adult. And this is what's happening. You can see in this graphic here. Obesity brings comorbidity and the so-called metabolic syndrome, especially diabetes and heart disease. And if you look at worldwide, you can see in the dark red here, when the incidence is very high, especially you can see India, Pakistan, Thailand, and also Philippines, a bit red, 60, 80, over 100,000 people. And why is more dangerous? Because you can see this intraoperative picture. Actually, higher BMI American Western people have much less fat than Asia. So the central obesity, the intraabdominal fat, is one of the factors that are higher risk for diabetes. That's why some studies have shown that anthropomorphic studies have shown that in Asia, Asian population 5% more fat at the same BMI, except the people from Beijing and North China that are similar to Western. So greater body fat means also higher risk for heart and for diabetes. So that's the main problem. And you will see this is a study done in Singapore, how the risk of hypertension in percent in women and men is much higher, and diabetes, how when the BMI goes up. You can see if the BMI more than 30, about 80% of the population have hypertension, and almost 30% has diabetes. Same when we project the overweight and obesity, a BMI compared to the number of people with diabetes, especially if you look at this study in Southeast Asia. And one strong player is the inactivity rate by country. You can see in Malaysia, the inactivity rate, so the lack of exercise is about 60% of the population. Indonesia, 30%, Philippines, 23, 24%. So this is the one factor that is very important. And diabetes also growing exponentially in countries like China, you can see 40%, or in Middle East or in India, 50%. So numbers that are terrible. That's why we classify the obesity a bit different from Western country, and the BMI and the indication for surgery are much lower. We go at 32.5, 36 to 37.4. We consider severe obesity with the very, very high risk. And indication for surgeries are 32 instead of 35. We have done as a society, when I was president, the PBMS survey that was did 5 years later also. So to analyze the trend of the obesity and the procedure in Asia. At the time, when we do a survey between looking at the 2005-2009, we have a number of procedures that are about less than 7,000. Maybe this number are not really realistic, but plus minus, we are around that. But the number are also showing that only 155 surgeons were performing obesity surgery in a continent that we are 4 billion population. In terms of procedure at the time, you can see that in the 5 years, there was a trend for the very low, very low number, going down number for gastric bending. There was the preeminent in Asia in the 2004, 2005, almost 50%, because we learned a lot from Australia. So, but you can see how in 5 years' time, already 10% less procedure. Why the number of Roux-en-Y gastric bypass went out from 10% to 25%. Same the number of mini gastric bypass, and the sleeve was going almost to 5%, very minimal case of sleeve. And this are the number specifically and the percentage. You can see how the increase of number was start to show that the sleeve gastrectomy was increasing at the rate of 25%, with a certain number not reaching even 1,000 cases all over Asia. The study was repeated in 2018, so almost 10 years later, and other factors also were analyzed in terms of what are the issues to perform laparoscopic surgery, what are the problems for the patient to access to the surgery, and mostly it was identified in most of the countries that the public health insurance was playing a big role. So the bariatric surgery was still considered a cosmetic procedure, was not recognized as a disease, so insurance was not paid. So that was one of the main issues for the larger use of bariatric surgery. But the number of procedures, that was about 6,000, 7,000 at the time, start to increase with an increase of 63 times. So, and reach almost in 10 years, almost 40,000 cases. And the number of surgeons also increased about 16 times from, remember, 155 surgeons to 1,000 in 2017. Especially the increase was mostly in the Middle East country, where the metabolic surgery was much higher. And there was also a dramatic change in time of procedure, where the sleeve from a mere 5% went up to 68%. The bypass is a bit stable, or let's say maybe went down from 25 to 20%. And other procedures still in the 10% case, like mini gastric bypass, adjustable gastric bending, and so on. Number of cases per country are listed here, but I'm sure you can get the paper, it's free online to get more information. What was the process, the evolution in that year? The number of cases that from 2007, you can see 2003 was 60,000 in 2014, but in 2018, in 1 year, almost reached 100,000, 95,000 cases in 17 countries. So there was a big boom of bariatric surgery, and more awareness and more support from endocrinologists. Also, the procedure started to be recognized in countries like Japan, Taiwan, Korea by the insurance system. So there was a bit a change in the difference. We do have also a split in the sub-region, and this shows how the case, the growth of the case are mostly in the UAE, the Saudi Arabia, in the Middle East, compared to other places. Why? Because the lack of exercise, the overrich food, it was much higher compared to the East Asia, where still the overweight, the waistline, the people are more concerned about their own personality compared to other people. This is a summary of the cases by region and how the number of cases grow, and we can see that the most common procedure today is laparoscopic cystectomy in the range between 60 to 70%, while the other procedures are less. Probably, I think the indication is different. We tend to do more bypass in patients that are having more stronger metabolic syndrome, diabetes, compared to the sleeve. So this is the trend of the procedure. You can see that today the gastric band is almost nil, zero. Only the mini gastric bypass keep this curve around 10%. The Roux-en-Y also is quite steady, ranging between 10, 20, 25%, while the sleeve become almost the queen procedure of obesity surgery. What are the current problem and the perspective? I think insurance and the healthcare system play a very important role because the access to the care also depends of the payment system. I think in terms of training and standardization of bariatric procedure, we are almost there because today we have several places where we can learn and we can, or events where we can learn and improve our practice. Awareness probably still, awareness among the other colleagues, they treat patients like endocrinologists, orthopedics, ENT, because of OSA. Still there is a lack of awareness among those kind of physicians, among also the public, because some people don't consider obesity as a disease, and the insurance company that still, we need to write a letter that is not a cosmetic procedure, but it's a life-saving procedure. The number of bariatric surgeons today probably are not still adequate, but are still probably adequate with the number that we perform today. Accreditation system, I think every country has their own system. So Asia play a big roles in bariatric surgery worldwide. You must understand that several procedures are started from Asia, like a mini gastric bypass, duodenal stitch, and so on. And I think you will see Kazu and Wei Jie is not around from Taiwan, but those are the people who really move faster in the bariatric surgery panorama worldwide. And probably in Asia, we do more metabolic than bariatric surgery because we have a higher rate of metabolic syndrome. And we need to treat more patients with diabetes. And today, Asia is very well known also for the number of study publications worldwide. So play a very important role in the bariatric surgical worldwide community. Thank you very much, and mabuhay.
Thank you very much, Professor Lomanto, for that very informative and colorful lecture. So it's not really so nice to know that poverty doesn't really exempt you from the problems of poverty. So I think we can conclude that Asians are fatter on the inside. So we not only have big hearts, but apparently fat hearts as well. Now, to give us a lecture on the global perspective in bariatric surgery, may I please welcome Professor Nathan Zundel. Prof. Professor Zundel, are you there?
I've not been, yes, I've been trying to share my screen. I've not been able to share. Will you allow me to share my screen?
Of course, yes, of course, Professor.
Because he's not allowing me to share.
Can our administrator at PICAS please allow Professor to share his screen?
Sharing of the screen is already allowed. You can share now, Nathan.
I'm sorry?
You can share. You can share your screen.
Can I share it now? Yeah, I can try. Yes, perfect. Thank you very much. Can you see it now?
You can see now. Perfect.
Perfect. So let me share it. It's good.
Perfect.
Okay, thank you very much. First, thank you for the invitation. It's early morning for me, so I'm even traveling, but I'm glad to be here. I want to thank everybody for the invitation. It's an amazing group of people. First, this is my disclosure from any company that I have any relations. So I want to mention a little bit about what Yves says that. Davide has been the executive director from IFSE for a while now. BARIATRICS is the International Federation of all the endoscopic surgical societies in the world. As you can see here, SAGES, EAS, our Latin American FELAC, the Canadian, Indian, Chinese, Korean, Japanese, ELSA. So we are a very big group of surgeons interested in minimal invasive procedures. But also we are a very nice group of friends. This is our last board meeting. As you can see, David is here. Most of the people who attend is here, people from everywhere in the world. But more important than that, we are all friends. And this was taken last year when I was in Thailand with this amazing group of people that you recognize. Some of you are here. So that's more important, that we not only share what we know, but only share good times and plan for the future, our societies and our procedures. So I've been asked to tell you about a global perspective. So we know we move from big TVs and flat people to flat TVs and big people. And that is a big change. And that only, I think in my own concept, we don't have any new changes in how we divide obesity. I think we need new classifications. I don't know how many of you, but I've done at least 10 patients or more than 90 BMI, a big amount of patients between 70 and 80. And we only have until 50, 60. So now BMI is above 60, we call it super, super obese, class 5. And now how we're gonna call over 70, 80, we call them triple X BMIs, but triple X super obese. But I think we're losing classification. A friend of mine from New York did 101 BMI recently. So I think we're moving to a much bigger people. And we know it's a world epidemic. It's not our only problem. It's one of the top 5 rash conditions in the world. It's been for a long time. And it's very easy to understand why. It's very easy because it's energy in, energy out, and we change the way we live. We change the way we eat. And now with all this pandemic that most of the people stay more at home, obesity is increasing more than ever. So we need to work hard in this one. We knew since I was a kid that a lot of people were obese in the US, in America, but we never heard that people can be obese everywhere. And this is the numbers that we have from the US. The more red you see, the more that 40% of the population is obese. But we have it also in Latin America, and that will be the global perspective, even that the numbers are a bit lesser. If you pay attention to this number, even that Brazil is the country who does second number of cases in the world. It's countries like Mexico and other places that have even a bigger incidence of obesity in kids. So we move just from one place to all over the world. You just saw David presenting how bad the problem can be in Asia Pacific. And if you pay attention to the 10 worst countries in the world, look at this. Kuwait, number 10. American Samoa, number 1. Nauru, number 2. Then you have Tonga, Palau. And this is places where you can have up to 75% of the population being overweight or obese. So most of the country has had those numbers. It doesn't mean they do the number of surgeries, because in those places, some of these places, they don't do it, but they have the numbers. And that's we need to pay attention to that too. Since 2000, and we're gonna move to now to the 20s, is we knew the numbers more or less about the world. And at that time, if you look at this, even that US was number 1, in Latin America, Colombia and Brazil were closer to that one, and places like China, Switzerland were having less. But now when we move, as you see there, now places like Brazil and Mexico, they took over about most of the places in the world. The other problem that we have is the only procedure, the only treatment that really has been working, you heard all the presentations today, still be surgery. In my mind, plumbing cannot be the solution to all these problems. But at the same time, it's what we have. And you heard the nutritionists, you heard the other specialists. I think we need to mix, we need to combine treatment to promote it. And that will be part of the global perspective that we have. we also need to understand that we are fighting not only that we overeat, we are fighting the problems in exercising. Most of the people who stay now at the office, and this year even worse at home, they didn't have places to go to exercise. There are some countries that going outside to exercise is dangerous. I know in Asia that's difficult to believe, but in many places in the world you cannot go out just jogging. You need to go to some gyms. But look how we promote obesity. This is mechanical, electrical escalators to go to a fitness center. So we promote obesity in many ways, and now we're trying to treat it. You heard today also about the surgical solution. We have the 4 classical ones. We have some new ones. So when the solutions are the same, even the sleeve that is relatively new, the sleeve is very, very old. So we don't have really much more solution for the patients, and that's what we don't cover everybody. Look how we move. This is from 2004, from Henry Bogwell. This is the number bands, bypasses we were doing in the US, for example. And when I presented to my patients what options do I have for them, I always tell them that the bigger the procedure, the more extreme the procedure, the better results regarding to weight loss, comorbidities, but the higher possibility of complications and problems in mid and long term. So I think the patients need to understand this, and this is something that is changing now also, and I'm going to explain later why. So we move to something like this, at least in the US. We were you doing like 70% of bypasses, now less than 30%. The bands went up to 25%, now less than 5%. The VBG is 0 now in the US. PPD and DS supposed to be increasing, but you see they move from 2.5 to 1.5. This is gonna change, and I'm also gonna explain why. And the sleeve gastrectomy, that is new girl in town, at least in many of the countries, 65 to 70%. It's important to understand that only 2 countries in the world still do more bypasses than sleeve. And that is Brazil, and that is Switzerland. The other countries, they do much more sleeve than bypasses. Those were the numbers for the American Society of Bariatric Surgery until 2015, where you see that still a fair amount of cases were bypasses, but the sleeve was gaining room. Look at the numbers now, and I'm gonna divide it a little bit. Look at the 2018, we just barely gonna have 2019 this year. We're still waiting for the result, but remember this year has been lost a little bit. So the number of cases were higher for the sleeve, close to 60% of the cases in the US, while the bypass, it was for the first time lower than 20%. But revisions, and that's one of the concern, and that's becoming a global problem too, revision moved close to 16%. So now we're having almost the same number of revisions or conversion than bypasses. So that can become an issue. And for the first time, some endoscopic procedures, BPD, is becoming a number. But when you compare the years, if you can see here, from 2011 to 18, we increased 100,000 cases. That's a good number. But if you look at that, in 7 years, doubling the numbers is not a bad thing. But with the laparoscopy appearance, with the safetiness we give now, we should be doing much more numbers. And look what happened with the sleeve, what happened with the bypass and the band, so you can see the changes there. I also wanted to present this one because I wanted to compare some of the specific procedures with previous year. So look, for example, with the sleeve, we moved from 28,000 in 2011 to 154,000 in 2018. On the contrary, the bypass is not that much change. Look at this. This was very interesting to me. We moved from 57 to 42,000. And the numbers are very similar for the whole 7 years. That only tell me that if it wasn't because we were able to bring another procedure like the sleeve, we wouldn't move the numbers. So patient is still looking for something that is new, safer, and probably better for them. So the appearance of the sleeve is what brought numbers up. Also, some endoscopic cases like balloons and some of the new suture gastroplasties, but also the revisions. We were doing only 9,000 revision in 2011, and now we do 30,000 more. So when you see these numbers, you understand that between revisions and new procedure like sleeve, that's what increases the numbers, at least in the US. This is the other, I brought this one because this is, I don't have the numbers globally for this, but I have the number for the US. I think we're moving to do our cases. We're gonna move to do them as an outpatient. That will address two problems. One, the scare of virus type like this COVID. So people are gonna have this in centers where no patient with COVID is even beer, or the next virus or whatever virus is coming later. So in 2018, out of 250,000 cases, 36,000 were done as an outpatient number. And that's very interesting also that even that most of them were sleeve, some of the bypasses, and even some of the revision, look at this, 14% were revisions done as an outpatients. Yes, probably most of them banned to sleeve. Still, we're gonna end up moving also to outpatients, and I think that's gonna happen too. We also know that there's gonna be a big growth of bariatric surgery finally, but it will be related to something else. Even in the US, that you know, we still consider the one anastomosis gastric bypass investigational. Look at this. In 2018, there were 100 cases of the investigational procedure called one anastomosis gastric bypass. Okay? There were gastric plication, very few noms, and when it's say unlisted, it's more of them are revisions or SADIs. So even that is investigational, the one anastomosis procedures are the one who gonna grow the numbers, if you ask me, in the rest of the world and in the US. This is, of course, SADIs. We moved to use it only for revisions. In the US, it's accepted now. It's no more experimental, no more investigational. You can do SADIs now as a primary procedure, and we do different techniques, but between SADIs and one anastomosis gastric bypass and revisions, that's gonna be the next number of cases we're gonna double in the world and in the US. So I compare with this with the IFSO numbers. This is the IFSO number that we have until 2016. Now we're doing a new one for 2019. And as you can see here in the world, and I can give you an advance, what you're gonna see is the last line, the one that is BPDDS, and the line that is blue, those two lines are increasing in the world as you cannot imagine. So in the world, one anastomosis procedures are probably, if it wasn't for Brazil, probably it will be probably number 2 after the sleeve. But Brazil does 120,000 cases a year, and most of what they do still bypasses. So it's very difficult to compete with that. So you have sleeve number 1, bypass number 2, and one anastomosis procedures number 3. If you remove Brazil from the equation, the one anastomosis procedures will be above the gastric bypass. And that's something very interesting. And also that tells us a message that maybe the patient is not that interested in having bypasses. The next thing that is gonna bring a lot of patients is the presence of COVID-19. This is the SAGES and the European Association recommendation for the response to COVID-19. We, as the American Society of Bariatric and Metabolic Surgery and the Latin American societies, that is IFSOLAC, we start to promote that we need to manage obesity because it's a big factor for morbidity and mortality with COVID. And now we have patients, a fair amount of patients asking how they can treat their obesity, what they can do for their obesity. So if they get COVID, they're not gonna die from that. So I think the scare of being obese, a comorbidity and a factor for mortality and morbidity for COVID is gonna bring more patients globally to our practices. Few last aspects to consider. First one, in our ethics, I've been taught all my life that I need to protect the patient first. Now, for the last 20 years, now I need to pay attention to cost too. In the US, at least, you need to be beware of malpractice, and then you pay attention to the safety of health personnel. So if something COVID teaches globally is that we were called superheroes, but in many places, a lot of nurses, physicians, health workers died without proper protection. And we are not heroes. We need to change what we think. We need, yes, to protect the patients. Yes, we need to pay attention to the malpractice. But the safety of health personnel is number one priority, equal to protect the patient. So that's the other thing that is changed more than ever. We need the safety of our health personnel in every procedure we do, open or minimal invasive or bariatric. So out of 18 million people who need surgery, specifically in the US, why no more? This is number one. People are still scared of the morbidity and the mortality of our more extreme bariatric and minimal invasive procedures. So we need to change that mentality. Even that we have data that doing a gastric bypass is safer than colectomies, even cholecystectomies, hip replacement, the patients still see it as a big change for life, and they're still scared of that. Also, we need to show them that if we do a bariatric intervention, we can reduce the long-term mortality of the obese population up to 7 years. You can reduce the mortality with a bypass up to 40%. And then people will die less from coronary artery disease, diabetes, cancer, and other problems. We need to make sure that our patients, our physician, our family practitioners understand this. Third one, we need also to understand that some patients, we don't need to do surgery on them. Some patients don't want them, we don't want them. So we need to don't waste our efforts and get bad results in those patients. We need to understand them better and decide not to do surgery in those patients. I think we need to focus in low BMIs, metabolic patients, and we need to focus in patients who really are committed to our programs. Diabetes will bring a lot of patients again, but we need to make sure that we are not gonna say that we cure diabetes because we don't. We need to make sure that we talk about remission. We need to make sure that we're gonna measure this with hemoglobin A1C. We need to make sure that having the diminishment of hemoglobin A1C from 8 to 6 change your life forever and change your problem forever. This is the message we need to send. No cure, no diabetes, and we need to do multiple interventions for those patients. So COVID is gonna change what we see, operations room, outpatients, changes in safe personnel, and a lot of people will come to have surgery. We need to make sure that they are safe, probably do them in centers, and this is a tendency is gonna happen in the US at least, some places in Latin America, that there will be centers away from hospitals, that they will be called COVID-19 free centers. In those centers, there won't be no patients with COVID, nobody with COVID will be there, and most of the surgeries will be as an outpatients. So that's the future. The other future will be that we're gonna move more and more to minus dramatic interventions, to more minimal invasive, are for sure endoscopic, but always if we can do this. So we don't have to be sorry. We have to do these procedures under ethical controls, select the proper patient, go to the endoscopy procedures, to minimal invasive, all of them under the proper studies with all the ethical components. So the future globally will be much less aggressive approach because the patients want that and we want that, plus real good medications. I think the combination of good nutrition, physical therapy, good medication, and less minimal endoscopic or minimal invasive procedures will be the solution for us. And we really need options for low BMIs, for the obese population before they become morbidly obese, for revision because we're failing a lot in revisions, and something that will be more acceptable for patients. Thank you very much for the invitation. I hope I can go to your country very soon. Thank you very much, guys.
Thank you so much, Dr. Nathan Sundel, for your very elaborate lecture on regarding your perspectives, the Western perspective of bariatric surgery. So please stay a while for our questions later. So for our next topic, we'll be talking about the Latin Americans' perspective in bariatric surgery. Now, Latin America has been a leader in several areas of both bariatric and metabolic surgery, and they are actually one of the innovators of surgical techniques like sleeve gastrectomy with transit bipartition and the ileal interposition, which are still under clinical investigation. But another significant area of Latin America is that they're also involved in the development of endoscopic techniques. So, and for tonight, we have Dr. Camilo Boza, who is the medical director of the Center of Nutrition and Metabolic Diseases at Clínica Las Condes, Santiago, Chile. He did his surgical residency at the Universidad Católica de Chile and had his fellowship training in advanced laparoscopic surgery at the University of Barcelona, Spain, with Professor Antonio Lacey. He's also completed his training at Weill Cornell Medical College of Cornell University in New York with Professor Michel Gagné, and he is the founding president of the Chilean Society of Bariatric and Metabolic Surgery. He has very extensive experience in the field of bariatric and metabolic surgery with more than 50 published papers in international journals and several book chapters. Let's welcome Dr. Camilo Boza.
Hi, good morning and good evening. Thank you very much, Alan and Dr. Sarmiento and all of our friends from Asia. We're missing so bad. The good thing about all the meetings, we're traveling, and now we're only are with the meeting and not the traveling, so that's a bad thing. But especially considering how far we are away from Philippines. However, we had so many good times in the area. Look how Alan had this time, and probably all of this bunch of guys in Bangkok. We regret many things the day after. However, I think it's a very interesting place, and thank you very much for the invitation. I really miss a lot. I live in Chile, in Santiago of Chile. Chile is a small country in Latin America with a lot of mountains. A lot of volcanoes, and with that we have many common things with Asia. We have very big volcano eruptions and also very bad earthquakes. This was the 9.0 earthquake in Chile 10 years ago on a 10th floor. However, we have been dealing with that in a good way. But we have other things in common. That we are having a lot of obesity. Latin America is rising with obesity, the same as we are having numbers very similar to what's happening in the US. Look what's happening in Venezuela, Mexico, Chile, and here we have more than 60 million people with obesity. What's happening with bariatric surgery in Latin America? Probably Nathan and the other presenters have shown what's happening. Numbers are going up. Definitely Brazil is a totally full world by itself. And what happens in Brazil, because of the size of Brazil, influences all of the rest of Latin America. We already showed that less invasive procedures are going up, like sleeve gastrectomy, and gastric bypass is going down. And I totally agree with Nathan when he said what's happening with one anastomosis gastric procedures. Although many of us, including me, are not happy with those procedures because they are taking probably the bad things about bypass procedures. And the only thing is that they are being very easy for the surgeon. But that doesn't mean that they are not. It's not a problem for the patient. And another thing is that what's happening in Latin America, and here I think I have to address the IFSO Global Registry report, that it's been a very interesting effort of all the countries to put all the data together. However, there's a lot of complexities about this data because depending on who is reporting, you can report more or less things. I was involved in the original registry when they started, so we helped a lot in building, at least from the data coming from Chile. But what is evident, and I don't want to get in detail because Nathan and all of the other speakers already spoke about the numbers, but I want to compare them with what's happening in Latin America. And I think this is a very interesting data on 2019 numbers with almost 800,000 operations. And interesting, Chile is a 17 million population country. However, we put more than 10,000 cases in the registry. Brazil still didn't put much because they were working with a pilot national registry. However, Colombia, they did put a good number of patients. And we see that other numbers like Mexico, that it's also a big country, put other few numbers. And here, if you compare the registry compared with other countries, we were doing quite a reasonable job in Latin America, Chile, Colombia, Argentina, Brazil, putting numbers in the registry. Other things is that the primary BMI of the patients that we put on the registry was quite low, and I will explain that after. And that's because the structure of our insurance companies here, public health, at least in Chile and in many countries in over Latin America, is not covering the surgery. This means that the surgery is being done usually in private patients that usually have private insurance and usually has lower BMI. So what the big problem here and the big public health problem is that we are leaving out of the treatment many patients that deserve and have a very good indication for the treatment, but they don't have coverage. And on the other side, we have lots of patients that are having problems with obesity, but definitely not as bad as the BMIs that we see in many other countries, but they are able to pay because they have the coverage. So that's why there's a complexity in the BMIs that you see. But here, when we see the primary, and that's why all the Chilean registries or all the patients done in Chile are mostly done in the private environment. So that's why the mean BMI in our country tends to be much lower. That's not because we are probably genetically similar to Asians or that we have more metabolic surgery, and that's because of the type of patients. And if we see the distribution of all the obesity-related comorbidities, we are having type 2 diabetes, we're having hypertension as much as the other countries. And I think this is interesting, and I think Nathan, he's a very nice guy, and he knows a lot, being former president of the IFSO Society, the Worldwide Society. What's happening in the world? Definitely, Latin America still has a lot of gastric bypass compared to sleeve gastrectomy, and this is definitely because of Brazil. I totally agree with him, because all of the other countries mostly are being done sleeve gastrectomies, and bypass procedures are going down. And although the virus of one anastomosis gastric bypass is starting to rise in Latin America, it's still low, but we are seeing a rising community of surgeons promoting one anastomosis gastric bypass, especially in Argentina. And we can speak about that. I don't agree that very much, especially because they are promoting that. I would agree that one anastomosis gastric bypass for high BMI patients could be reasonable, but I don't think that a BMI of 35 with a one anastomosis gastric bypass is going to be reasonable. And here we see the type of procedures, and on the right you see the sleeve gastrectomy, and you see that there are many countries that are performing mostly sleeve gastrectomies. In Chile, we are right more or less on the middle between sleeve and bypass. However, in Chile, we are not doing one anastomosis gastric bypass, and we are promoting much more endoscopic procedures. Why is that? If you see the typical image of a patient, maybe morbidly obese, but without metabolic syndrome, you will see this type of fat. If you see a patient with diabetes and metabolic complications, you see the type of fat that we see when I do a surgery in Asia, that you see, oh, this patient is not very fat, but when you get in the surgery, you start saying, oh, this operation is going to be a nightmare because of the intra-abdominal fat. But the main thing here, at least in our country, I had the opportunity to be part of the metabolic surgery consensus statement about stigma, and I think it's crazy. We are speaking about metabolic surgery, more than 20 prospective randomized trials, etc., but we still don't see enough metabolic surgery patients, and we see always the patient that wants to lose weight. So this is the big problem. And here I think, look how the difference between cancer and obesity in terms of the prevalence, and look the funding for obesity versus for cancer. We're seeing 10 times more funding for cancer research, and we see very few research for obesity. And I totally agree again with Nathan on what's happening with COVID, that hopefully COVID will make people more aware of what's happening. And what's happening, that still, with all of our efforts, less than 1% of the patients are having surgery. So this slide that I stole from Jaime Ponce, I think, as all of them have said, surgery is still very low percentage, and patients are asking for endoscopic treatments, from less invasive treatments, and they can deal with that. And I think the ellipse balloon has been a very impressive example. We have been putting endoscopic balloons for many years, but we usually put around 50 or 100 a year. However, with the start of ellipse balloon, and the two critical things, no anesthesia, no endoscopy, 10-minute procedure in an outpatient system, had made, this is how it looks. Do you see the video, hopefully? This is one of my patients. Look, the time it took to put the balloon. So basically, in probably, this video is not edited. So it took me 31 seconds to put the balloon in place. Then you connect the balloon, the patient is there, then you take a picture, the balloon is in place, and the patient, you take away the catheter, and the patient, that's what's happening. There's almost no addition, and the patient goes home. So this is what patient wants. So this is what we are seeing. And although at the beginning I said, oh, this is the same balloon, it's only 4 months. What's the main difference? But just because we avoided endoscopy and sedation, this thing totally was something that blow up our mind. And we have done now more than 300 cases in a few months, and patients, although it's less invasive, although the results are less than impressive than surgery, definitely, but for a big number of patients is the way to approach to something. However, not everything is fantastic. This was one patient that had a ellipse balloon, and she had a bowel obstruction. It was a partially deflated balloon. So what we did is that we were able to puncture with the partially deflated balloon, and the patient was okay. However, sometimes we can have patients with problems, and we have to have an early retrieval of the balloon. And this balloon, if we have to retrieve, sometimes it can be much more complicated because deflation is more difficult. So there you have a deflation tends to be much more difficult than the usual balloon. This is the way it looks when you have to take it out from before the end of the period. So now we have done in Chile 1,200 balloons in just in the last 8 months. Chile is the only country in Latin America that have been able to have ellipse balloon because we had the approval. Just in our unit, we have put only 361 balloons here at Clínica Las Condes. We have had 6 patients for early removal and 1 bowel obstruction on the patient I told you. So this is what's happening. And another procedure that I wanted to speak about, if we have minutes, just let me know if you have to finish, has been endoscopic sleeve gastroplasty. Brazil has done an excellent job with Manuel Galvao and all the team from there, where they've been growing numbers. We started doing endoscopic gastroplasty 2 or 3 years ago, and we have a good number also. But here in 1,800 procedures, they have a mean total body weight loss of 18% in 1 year, and adverse event happens in almost 1%. So we are performing endoscopic gastroplasty in patients with BMI between 27 and 35 usually. We tend not to use endoscopic gastroplasty for patients that has a good indication for bariatric surgery because the results are not good. Most of the patients are discharged on the same day, and patients are very happy with these procedures. In our unit, we have performed 240 patients since 2017. I want a small video just to show you. At the beginning, I thought that endoscopic gastroplasty was basically one crappy endoscopic thing that was not going to result. But when we started doing a better job, putting more stitches, doing the thing, we started seeing that definitely this is surgery. Patients are having the same feeling of a endoscopic of a sleeve gastrectomy. Definitely the results are not the same as sleeve gastrectomy. However, it's a very good start for a patient that wants something that is more permanent than a balloon. And if you see here, I'm showing you this a bit longer video just to show you how this is a patient we did, a patient we did last week. And look how we are leaving now these rings of suture we are doing around the stomach. And now that we are more skillful for doing surgery, we can perform more and more stitches with the same round. So here I want to show you how it looks at the end of the first stitch. And this is how it looks. So now we are placing the place, and this is the first we are pressing now. Look how it looks, the first ring. And now we do this 3 or 4 times, and this is how it looks, that we leave a tubular stomach without touching the fundus. And one thing that is the big problem of the sleeve gastrectomy, without reflux. There's no reflux in endoscopic gastroplasty. So we've done these 200 cases. Usually Brazilians tend to have much better results than everyone else. So in our case, we are seeing a total body weight of 13%, not 18 as what we are seeing, probably because our BMI of our patients is around 30. So that means that we are having less BMI patients, and that means that probably we are seeing less total body weight. We haven't seen big complications. We had in one patient one pneumoperitoneum. The weight loss has been reasonably more than 60%, reached the goal of more than 25%. Half of the patients had reached more than 50% excess weight loss. And we had one gastric perforation that was treated laparoscopically, one pneumoperitoneum, and 2 bleedings that resolved spontaneously. This is one interesting case of a patient that had pneumoperitoneum. She came back the same day, but it was treated with NPO, antibiotics, and we didn't have to do surgery or anything. So this is surgery, and we need to continue comparing with the big patients. And again, I agree a lot with Nathan that the next final thing, just to tell the concept, that we are doing more and more and more revisional surgery. Sleeve gastrectomy here in Chile is 80% of bariatric practice. So if we have so much sleeve gastrectomy, we are seeing this. So this is what we are looking. Patients coming back with big hiatal hernias. You think there's nothing there, but then you start realizing that the stomach is going up after a sleeve gastrectomy. So we have to dissect and we have to bring down the stomach if we want to definitely reduce and treat the reflux. So to conclude, we've been very active in bariatric surgery. Metabolic surgery is still with stigma. Honestly, I think we will get better in minimal invasive procedures, but with metabolic surgery, I don't understand why, probably because of new medication, but our colleagues are not sending the patients. New technologies are very promising. Less invasive, you will have less results, but less invasive needs to be safer. You cannot start offering things that are less invasive, but that have complications. Thank you very much. I really miss to be there. And if you have any questions, thank you.
Thank you very much, Professor Bozan. That was very interesting to see endoscopic options in the management of bariatric surgery apart from the usual medical lifestyle and surgery itself. Now, I'd like to introduce again our panelists who I think some of them might want to make any comments and share their thoughts on the previously discussed topics. We have Dr. Kasama, Dr. Sutep, and Dr. Florence Gan, and Dr. Jaideep, and Dr. Don Rosello. Do you have anything to share before we move on to the our questions from our audiences. And also Dr. Ike and our other guests we have invited, our distinguished leaders and the other members of the UMIST program. Okay, maybe we can start off first with in the medical side, in the medical field. I think Dr. Florence Gan has some thoughts to share.
Thank you,
Dr. Florence.
Good evening, everyone. Many thanks to the organizers for inviting me to this wonderful activity. It is my great pleasure to be here tonight. So like what everybody mentioned, while we are staying at home for our safety, the obesity pandemic has now been laying on top of the ongoing pandemic of COVID-19. We know that excess weight goes hand in hand with other medical conditions, which by themselves make it harder to fight COVID-19. And this discussion is truly very timely. We all need to fight and curb the growing population of patients with obesity. And I agree that while BMI is a good approximate parameter, it is not precise. For one, it doesn't specify exactly where any excess fat is located on the body, nor does it make a distinction between muscle or fat. In this regard, more than the BMI, we should also look at the body composition, since body fat is an equally important information in the management of obesity. So in a recent article, I just want to share this with you that in September 2020 in the British Medical Journal, they have correlated central obesity with all-cause mortality, and it states that for every 4 inches or so additional weight circumference, this increases early death risk by 11%. So during the lecture of Dr. Leiko, she has brilliantly highlighted the multidisciplinary approach to treatment of obesity, starting off with a good history and physical exam, diagnosis, meal plan, physical activity, behavior, and ending with different pharmacologic options and eventually the option for bariatric surgery. And I totally agree with Dr. Woolbright for sharing an encompassing insight on the challenges of medical therapy. We know that while diet and physical activity can be done, it may be hard for most of our patients. We are fortunate enough to live in an era with more pharmacotherapeutic options that can both enhance initial weight loss and improve long-term weight maintenance. Okay. However, we should also remember that medications are just adjuncts, and clinical trials for obesity pharmacotherapy consistently demonstrate that weight regain when active treatment is withdrawn are important to be inculcated in their new normal lifestyle. Hence, we need to go back to the basics with lifestyle and behavioral change. We should also understand that the set point model states that the body has a regulatory system that keeps you at a steady state level or set point. So according to this theory, after a certain time that the patient or the body of the patient will fight reduced calorie intake by sending signals like hunger pangs and slowing down the metabolism to attempt to bring back the patient to his normal set point. That is why it is hard to lose excess weight, especially for patients with severe obesity. At present, there is a trend towards hormonal therapy for obesity treatment, and we have GLP-1 receptor agonists in the market. And obesity researches are underway that focuses on different gut hormones. And it is anticipated that administering combinations of these hormones will be beneficial to address the highly redundant hormonal physiology that defends body weight. And this is something we can look forward to. And I would also like to reiterate that only consistent predicted later weight loss is the initial weight loss within the first 3 months. If clinically significant weight loss is not achieved within the first 3 months of treatment, then we should reevaluate and we should look into the factors contributing to perceived pharmacotherapy failure. And this would include inappropriate dosing or adherence, barriers to health behavior, and psychosocial or medical issues, as well as economical issues as mentioned by Dr. Goldbright. On top of this, we should also recognize that patient response to pharmacotherapy can be varied. Currently, we have no ability to predict which medication will benefit most of our patients. Probably in the future, when there is hormonal and genetic profiling, it may be possible to predict which cocktail of medications will work for a certain patient. One more important challenge in the medical treatment of obesity is that in spite of the number of people living with obesity, not all health professionals may be equipped to help and support these patients. I also believe that there is a need to increase awareness on obesity care. Endoscopic procedures has now been on the rise, and thank you, Dr. Boza, for sharing with us your center's experience on this. And this can be a good option for patients who fear to go under the knife for weight loss. One issue that we should also remember is that bariatric surgery bariatric surgery can be discussed proactively and offered at the onset if indicated, and not be the last option for treatment of obesity. We thank Dr. Lomanto for highlighting how bariatric surgery is in the Asian setting, and let us all strive to increase bariatric surgery awareness. Lastly, bariatric care does not end after the patient undergoes the surgery, but it is a lifelong journey with the patient. I hope that together, both physicians and surgeons can work hand in hand to fight and win this, to win the fight against obesity. So thank you.
I have one question, Doctor.
Yes, Dr. Boza.
So to all the panel, I just wanted to see what you're seeing in Asia, and it was basically part of my one of the last slides, is that although you see that Asia has less obesity than the rest of the world, but more metabolic and more sick patients. And I think this is good and bad. It's good because there's more indication for surgery, but it's bad because we are seeing, at least in our country, in this side of the world, that patients are going by themselves to ask for treatment. My patients come because they see a nice case, they had a relative, they have a friend, they saw it on TV, and they say, I want that because I want to lose weight because I've been dealing with my whole life. However, with all the stigma of obesity and metabolic surgery, even with the 15 prospective randomized trials, at least in our practice, I am not seeing more metabolic surgery patients. I'm not seeing more diabetics, I'm not seeing, but what I'm seeing is more patients with 10 or 15 kilos that want to have a balloon, basically that the primary the primary thing has been the will to lose weight, not to treat the disease. And this is because physicians are not referring. It's because they feel that new drugs are treating diabetes fantastically and they don't need surgery. What's happening in Asia with referral? That's for all the panelists.
Okay, let's start with Dr. Leiko and Dr. Wilbright. Do you have any comments on this?
Hi. Well, in my case, what I noticed is that the main problem is awareness. Patients really do not see it as a disease, so that's one obstacle. And Dr. Woolbright had mentioned a lot of obstacles, and there definitely in the Philippines the finances will be an issue. So that's the reason why we can't refer a lot of patients for this metabolic surgeries.
Yes, I think for the Philippines, although we do have a lot of metabolic patients who would classify under the metabolic surgery, it's not just the patients themselves, but even the physicians, especially the physicians, they don't really refer right away to surgeons for metabolic surgery. They always try first the medical management. And the problem is because most of our patients are paying on their own, the moment they don't get better, they go to another doctor. And so the cycle continues, and then they never get the metabolic surgery. We don't have insurance for metabolic surgery, like the problems that you have also with funding. We don't have insurance for elective procedures such as that. So our PhilHealth, Philippine Health Insurance, only covers really severe cases, and even at that, a very small amount only. So I think we still need awareness, because I think it's really a growing problem, and it's a problem that doesn't seem to be solved very well with medical therapy.
Yes, and I think also maybe an intervention to the government administration is also warranted to help not only in terms of healthcare, but also in environmental administration, such as the maybe tax price, as what they're doing in other countries, tax pricing on sugared products and beverages, higher pricing of other non-healthy food options, and probably making the more our environment more suitable for a more active lifestyle, right? Okay, so we have I have another question for our internists. How long do you usually, especially in the Philippines, people tend to have a stigma against undergoing surgery because of the idea that it is cosmetic. Now, how long would you usually offer the patient to do a trial of lifestyle change before you actually really insist on them having to undergo surgery? Because most of them initially will just tell you, no, I don't want to have surgery because of the varied reasons whatever reasons that they have. So, doctors? Dr. again?
You first, Doc, or me?
First, Gloria. Go ahead.
Dr. Agan.
Go ahead, Dr.
Okay. Hi, Doc. So in my experience, Doc, when I suggest bariatric surgery for my patients, they actually decline. There's that stigma, they decline. And then how long do I keep them on medical management? I keep track of them every 1 to 2 months. And if I see that there is progress in the weight loss, I usually keep them for a long time until we achieve the goal. Because the goals for the medical management, when you have a really obese patient, it will take up to 3 years or more. And so most of the time, it really takes a slow progress. And so I keep them while they have progress. But when they revert, because they gain again the weight and they get frustrated, then I show them that even with really intense therapy, it's not possible. It's not worth the wait. So that's why I suggest more of the bariatric. But usually it's really, really labor intensive to make sure that they follow up. And there's also a psychological aspect where you really have to make them understand that you care, that your point is to really have weight loss, that you follow them up. You're really the one who says, hi, how are you doing now? You know, because if you don't do that, they will come back the moment they're 10 kilos more.
Yes, and what about you, Dr. Aleco? How do you bargain with how do you haggle with your patients?
It's quite difficult really to convince them about metabolic surgery, because of the moment you mention the word surgery, they will give you this weird look. So really, in especially in our country, so the acceptance of bariatric surgery or metabolic surgery as a solution to obesity is still an ongoing problem. So of course, from the onset, they decline surgery already. So what I do is just I start them with medical treatment, the diet. I talk to them about the diet. Then in every visit, then I discuss the surgery again. But you have to understand that these patients, it's not only the medical aspect that's going on. They have a lot of things going on. So you have to know what stage they are in, also the acceptance stage.
In connection with this one, everybody had the same problem when they first started, like in Hong Kong, when they first started doing bariatric surgery, they had the same problem. How were you able, the question now is, how were you able to convince and how were you able to change the way of thinking from people from, still in connection with the question of Camilo, in the Asian side, how were we able to convince our patients to go into bariatric surgery in Hong Kong, Singapore, or even Japan, especially Japan, knowing all Japanese people are quite thin, quite, because of their activity. How were you able to convince these people to go into a more aggressive form of treatment like surgery? Maybe we can start off with Simon and then David and then maybe Katsu.
Okay, so in Hong Kong, I think we are starting in more than about 20 years. The first few 10 years is hard because we don't have much cases initially. But I think a lot of people are looking at outcome, and then you need to have a good outcome with low morbidity, and then people start to trust you. And then you need to work on the policy and also the insurance side as well. Because in Asia or in Hong Kong, the treatment is not just obesity, but diabetes, because about half our population half the surgery populations. So we are trying our best to convince our government that this is good and with good results, so that they will support in the public. On the other hand, on the private, of course, not all of them are covered. So you need to sometimes make more exposure to the media or news in order to get the awareness of this kind of treatment is safe and effective. So it's difficult, but it's doable. But make sure your patient alive. That is the most important. So not to make big news out of everything, and then work it up with our physician colleague and also our policy maker, and sometimes talk to the insurance company and so on.
How about you, David? I know David had a bariatric group in NUH, and you're the one who started actually the bariatric program in NUH. How were you able to convince and then try to change the form of thinking of patients in Singapore?
This is a very good question. I think it's always, I agree with Simon, it's always a challenge. I started when I came to Singapore in 2003, but I think the program until really took quite a long time. Why? Because of the outcome. As Simon said, people want to see the outcome. People want something that works well, have a very low, no complication, no general anesthesia, no surgery. That's why, as Camilo showed, balloon, all this endoscopic surgery may work in a small group of patients that are not keen for surgery. But the outcome, we all know the outcome is relatively poor. So I think doing a good job, small volume at the beginning, and slowly create a reputation, work together with the endocrinologists, even though our referral mostly are from orthopedics, ENT, because of patients that really require to lose weight because they need to go for a knee replacement or have a severe OSA. So at the end of the day, the better allied are not the endocrine people, as we will believe at the beginning. I'm so sorry if there are any endocrine around, but the best, our referral come from all very strong GP, general practitioner, or mostly orthopedics, ENT, other specialty. So of course, then by practicing and having low complication, good outcome, and by example from other patients, you get a referral.
Thank you, Dave. How about Katsu? Is Katsu around?
It's not around, Katsu.
I was here.
Not around yet.
How were you able to do it, Nathan, in your in your practice?
You see, I think I do practice in different countries. In the US, it's more complicated. In the US, we still go by the NIH consensus of 1991. So we cannot do nobody below 35 with comorbidities or nobody below 40 without comorbidities. So we don't have that kind of metabolic surgery. We don't have that kind of cosmetic early obesity surgery. So in the US, it's complicated. Outside the US, in the other countries I go, I like the Camilo's comment, and I want to discuss a little bit with David about this comment. I understand that endoscopic interventions are not exactly as we expect them, but I see obesity as a chronic disease. So I think like hypertension, asthma, pulmonary diseases, you're gonna need to do multiple interventions in a lifetime. So we can not only do drastic interventions. So if you start with a balloon, then you move 2 years later to a gastroplasty. If the patient is diabetes, maybe you move to duodenal ablation, or you move to something like prevent you to absorption in the duodenum. I think those interventions will help 2 years. Then you do another intervention for another 3 years. And if you combine it with medication, physical therapy, changes in alimentary behavior, then they will do better. Yes, probably then don't do anything for 60 BMI, 80 BMI, but, and I don't want this to sound discriminatory, but every time you speak about this, they say cost effective. If we're really gonna pay that much attention to cost, I rather, if I have $100, I rather invest 80 or 90 in BMI and people who will do better with time. Sometimes we invest most in our 90 BMI, 70 BMIs, and they don't move back more than 50 or 45, and then they come back. If we invest money in multiple combined interventions, I think we're gonna do a better job for those patients. So that will be my comment.
Okay, thank you very much, Dr. Sundel. Any other comments from our panel?
Dr. Don?
Yeah, I'd like to make a comment. First of all, I think, can you hear me? I think here in the Philippines, there's no stigma to having obesity. There's no stigma. I mean, like, you know, there's a bigger stigma to undergoing surgery for bariatric surgery. I did bariatric surgery for like several individuals who asked me, you know, please, let's keep this a secret. Don't tell anybody. There was one, like 3 sisters. The 3 sisters, 3 of them, I did a sleeve gastrectomy for all 3 of them, and they've had excellent weight loss until this time. And they told me, you know, please don't tell anybody. And then they tell their friends that, you know, they did not go under surgery, and they just, you know, did exercise and everything. And they told me, you know, we're so sorry, but we can't refer patients to you, any other patients, because we're not going to tell anybody that we underwent surgery. And I think the main problem here in the Philippines is also there's this big hindrance with the government. Because in reality, we've been doing it for a very long time. If Simon remembers, I was Simon's cameraman in the first gastric banding that they did in Hong Kong back in 2002 with Professor Sidney Chung, and Simon was doing it. But I started in 2005 here in Cebu, but still, you know, the numbers are not really increasing that much, and it's been a problem. In our government, there's a lot of hindrance to bringing in stuff, and I appreciate, you know, hearing that in Chile they're doing a lot of endoscopic sleeves and a lot of new, you know, devices that are available, easier to put in. Balloon, we know that, you know, we've had the balloon for a very long time. We know that even from the studies in Australia that it's effective for up to 2 years, but the failure rate up beyond 2 years is more than 80%. These devices, Dr. Ray Sarmiento would agree with me that, you know, we've been trying to bring endoscopic suturing devices into the Philippines, but until now, it's not available. It's hard to get it in. and the government is not helping us. Maybe the first thing that we do in the Philippines is to educate the Department of Health. Did you know that it's just recently, because I worked with Novo Nordisk in trying to get Saxenda in, it's just been brought into the country less than 2 months ago, and available in Mercury Drug just a few months, or just last month or this month, and that's really difficult. I would like to ask the other panelists. I'd like to take this opportunity to ask the other panelists, what are your experiences, for example, like with other endoscopic devices like the endo barrier, which really never reached the Philippines? The endo barrier.
We had experience with endo barrier here in Chile. We did many of the original studies, but there was a big problem with the barbs putting in the duodenum, and we started seeing hepatic abscesses. So all the trials were stopped. I think the concept is still attractive, but I think maybe Nathan has more information that they were developing some different device of anchoring, because making holes in the duodenum is not a good business probably to doing any type of procedure. And it was very symptomatic, and when they were complications, the complications could be very serious. They could be bowel obstruction. The patients lost weight basically because of pain, because there were a lot of pain having these barbs inserted in the duodenum. This was, and I have to say that for me, it's been a surprise how well tolerated is endoscopic gastroplasty. It's crazy. The patients really feel perfectly the next day. And you said we've been putting balloons for several years, but when you have available ellipse, it's a totally different world. When you tell us someone that go to next door, swallow this capsule and go home, that amplifies by 100 times the patients are going to be eager to have the procedure. And the other thing that is important to see, that don't put balloons in BMIs of 40. Put balloons in someone that has excess weight load of 10 or 12 kilos, because those are the patients that are going to benefit. If we still continue to put on a BMI of 40, a balloon is going to be like I've done like 3 or 4 ellipses in high BMIs, and when you start putting the balloon, you said, "Are you feeling something now?" And they said, "No, I don't feel anything."
I have a comment to Don question. So I think that any intervention that we do by endoscopy in the stomach is going to be just related to weight loss. Any intervention we do in the intestine, it will be metabolic. And if we understand that, then gastroplasty is not comparable to duodenal ablation. They are nothing to do one with the other one. So in the case of endobarrier, I think first, to be fair, the results related to diabetic control were pretty good. So if you prevent food to be absorbed in the duodenum somehow, like we do in the bypass, like you can do with the endobarrier, like you do with duodenal ablation, the results in diabetes will be good. But we need to do it safer. And I agree with Camilo. And endobarrier in the first trial, they had a lot of hepatic abscess in the US, so was suspended. But they were going to start this year the second trial with modification in the anchorage, but it was postponed for the virus. But they're gonna do it. But also there are 2 people in Asia, one from India that I'm aware, and one from Korea, if I'm not mistaken. They're doing different ways of doing the same with a different type of fixation. There are 4 companies now doing duodenal ablation. So I think the metabolic intervention in the duodenum won't have to do anything with weight, BMI. It will have to be all with a metabolic, and that will be good for, especially for Asia and some other places where patients are skinny.
Thank you very much, Professor Sindel. In relation to the endoscopic interventions, there's a question here to Dr. to Dr. Boza. How do you prepare patients for ellipse balloon? Do you give antiemetics and steroids prior to balloon insertion? By Monica Behasa.
I think what I tell patients, one of the main things that at least in our practice, we have a quite big bariatric unit, obesity medicine unit here. We see around 2,000 patients a month. So there's a lot of patients asking for treatment. But the good thing is that you can offer many of the things. And what we do for ellipse balloon, and when we compared ellipse with gastroplasty in terms of preparation, I say to the patients, ellipse balloon is very easy because you go 10 minutes and you have the balloon. However, the next day is a nightmare because you will have then 2 or 3 days of nightmare, of pain, of colics and everything. However, now with the new medication, we are using Akinzio. This is the droperidol with isofran. It's a mixture, and it's working very, very well. Antispasmodics. We give a quite big cocktail of medication for starting the day before and 5 days after. And with this, we are having, as you saw, not more than 0.2% of retrieval of early retrieval.
Okay, thank you very much, Professor Boza. And since it's already almost 10 o'clock, we only have time for one last question. So Dr. Lamanto had mentioned that there's already an increasing trend of obesity in the pediatric population in Singapore. But to all the panelists, for you, what would be the youngest allowable age for surgery to be done, to be recommended in the pediatric age group? Of course, that we would have to consider the closure of their bone plates prior to doing any drastic surgical procedure. But for you, when would you already recommend that these pediatric population are candidates for surgery, apart from those with Prader-Willi syndrome, which are still is not actually recommended, of course? We can start with Dr. Lomanto.
Oh, yes. What is the age? I think we should strongly start with a very conservative management, means lifestyle, diet, and exercise. If you really need to do a surgery, I will go for only for a restrictive procedure, and maybe minimal age is about 16 to 18.
What about Dr. Sundel?
I have a different opinion a little bit about, we did a lot of adolescents and kids, and I was not planning to do them. I did them when we started with the band, and that was like 1995, 1996. And it took me a lot of time to decide to do the first one, that it was a 14-year-old, like 145 kilograms, that he quit school for 2 years, and he was very big. And I say, they were making very bad jokes to him in the school. They bullied him. I say, you are too big. Why you don't kick their butts? And then he said, it's not in my temper. It's not. So we did that first surgery, went very well. Then we did a lot of surgeries. We moved to sleeve as soon as we have sleeve, because I think it's much better for kids. And we're doing now some endoscopic intervention to some of the kids for the same that I mentioned before, interval interventions. But I don't go by the age anymore. The youngest one we did is 9-year-old. And we did it because it was a kid close to 100 kilograms. So I go more, not even BMI. As you all know, pediatrics and adolescent BMI is not the perfect things to go by them. But I go by the social situation. I go by the weight they have. And I also go about the parents, because we spend usually more than 6 months talking only with the parents, because sometimes are the parents pushing these kids to have the surgery? It's never the kids. So we need to be much more careful with them. I think the decision in the US, I'm not sure about the decision in Asia, the decision in the US that we only do pediatric and adolescent in certified centers with pediatric surgeons, with pediatric psychologists, that's a much better decision. Probably that is a group that should be focused in that way.
Okay, thank you very much, Dr. Zundel. And what about in Hong Kong?
I'm sorry.
Oh, sorry.
Yeah, I would agree with that. Then, as you say, we want to do it, but our pediatricians are not happy, and we don't have a clinical child psychology that is helpful. So I decided not to start with a pediatric, because that will be a troublemaker if they have something wrong, either in the press or in the hospital or whatever. So when we start, I think I would start with something safe. But at this moment, when it's mature, I start to find them again, and probably may start another team later.
Okay, thank you. And Dr. Boza, what about the situation in
No,
Chile?
I received last week a patient, 11-year-olds, almost 100 kilos, and they've done all of the medical treatments the whole life of that poor little child. And that child told me, doctor, if you can do anything that I can get rid of this obesity from me. And it's crazy how ruthless are many times pediatricians that they say, no, you cannot do that. And this patient had already developed the plates, and they are always, usually women tend to be overdeveloped in terms of their height and everything because of insulin resistance. So I cannot, honestly, I cannot tell what thing can be worse for those poor kids. And I think it's very irresponsible from the medical community that we tell, oh no, I don't want to have trouble with those patients. I get rid out there, but they're not doing anything. They're not solving anything. The treatment for those patients, it's always a disaster. And they have a 90% possibility of being morbidly obese when they are adults. So I think it's very, very cruel what we are doing, honestly. I really fight with them in every meeting because they are, if they were offering something reasonable, or not even reasonable, decent, but they're offering nothing. And they are blocking to develop procedures, surgery on those patients, because I honestly think that they will not have a worse outcome in terms of endocrinology or development. They will always be worse. So it's very frustrating. I'm not a pediatric surgeon, so I don't care. But every now and then I receive a patient like that, and it really, the last one, I almost start crying with the poor patient, saying, I totally understand you, but I think it's I'm not sure if you have the same opinion, but I think when I see someone suffering like that, I think it's very, very cruel, really.
Okay, thank you so much,
But
Dr.
sorry, if they allow me, I would do surgery in anyone, honestly.
Okay, thank you so much. So I guess it's getting late. Dr. Don Rosello, do you have any words to wrap everything up?
I would just like to thank everybody, all the speakers, all the panelists, all the organizers, you as well, Michelle, and Dr. Bonifay, and all the chairpersons. Thank you for sharing your insights, and thank you for sharing your expertise. So have a good evening, and nice to see everybody. David, Simon, and nice to see everybody. Thank you.
Thank you guys for the invitation. Yeah.
Thank you very much.
Thank you for the invitation.
Thank you. Bye-bye.
Thank you very much.
Yeah,
Bye,
see
Nathan.
you next week.
Thank you so much, Davide. Thank you. Camila, thank you so much. Karen, and of course, Dr. Leiko, and of course, all the moderators. Mitch, thank you for a very nice program. And of course, Don and the UMIST group. Kuya Ike, is Kuya Ike still around?
I think he fell asleep.
I'm here, Kuya. I've been listening the whole time. Congratulations to everyone. Excellent
Very interesting.
excellent lecture. Good job, guys.
Very interesting session. We would like to give the floor to Kuya Ike to wrap it up and then finish everything. Thank you, Kuya Ike.
Closing?
Yes, please, Kuya Ike.
Okay. Thank you. Thank you, Kuya. Anyway, it was truly an interesting webinar, and I've been listening to all the comments of our friends from the international community, sharing all your experiences from the medical aspect to the surgical aspect and to the endoscopic aspect. And it's truly very important to realize after this session that a multidisciplinary approach is truly very important, involving a lot of specialties in the appropriate management of patients with metabolic and weight problem issues. So that is something that we have to consider as a very important lesson here. And it is always important in bariatric surgery as well as metabolic surgery that we get the experience and knowledge from people with high volume cases in other areas that we can adapt here in our country in order to help our patients suffering from this dreadful disease, which is truly a disease that we have to manage both medically, surgically, and endoscopically. So that is very, very important. So again, thank you very much, Kuya Allen, Kuya Ray, Kuya Don, Roselio. Congratulations on a successful webinar. And more importantly, thank you to our invited speakers, both internationally and locally, for sharing your experience and knowledge with all of us. It was truly a fruitful event tonight. Thank you very much.
Thank you.
Thank you everyone again for attending. We hope that the audience was able to enjoy our session today, and I hope everyone will be anticipating our next session next week, wherein we will be talking about how we do each type of basic procedure, and it's also going to be star-studded with our amazing guest speakers. We have Dr. Chikun Huang from Taiwan, Dr. Mufi Lakdawala from India, Dr. Philip Gan from Australia, and Dr. Manuel Neto from Brazil. Okay. Good night, everyone, and thank you again for attending.
Thank you. Thank you, Mitch. Thank you.
Thank you. Congratulations.
Bye-bye.
Cheers.
Thank you. Good night, everyone.
Thank you, everyone. Alan, thank you. Good night. See you next on.
Hey, Simon. Bye.
Right.
Kuya, galing. Congrats.
Kuya Ike, thank you. Bye-bye. Nice meeting you soon, Kuya Ike.
Thank you sa inyo. Thank you, guys.
Ray, Sarmiento, salamat.
Kuya Don, thank you.
Very nice program. Kuya Don, thank you. Galing yung program mo.
Kuya Ray, thank you.
Thank you. Thank you.
Bye-bye.
Next week ulit, masaya pala dito, no?
Next week, Kuya, is the procedures.
Maganda yan, maganda yan.
How I do it.
Second is the RUY, and then MGB. Tas yung endoscopic kay Manuel Galvao Neto.
Nice.
Sa third week, maybe we can also discuss yung ERABS.
Yeah.
ERABS, enhanced recovery after bariatric surgery.
Maganda yan.
Because it's part of trying to avoid the complications. Because ganun yung shift din. Because especially now that they're trying to push for outpatient na sleeve gastrectomy. So ERABS talaga. Yung preparation prior to surgery is very important.
That will be a good topic.
Maganda mag-lecture doon, Arabs. We can invite.
Congrats, Michelle. Good job.
Thank you.
Maybe yung friend ni Michelle, yung isang panelist, si Dr. Gan ba yan?
Dr. Gan is endocrinologist.
Maybe she can talk a little about ERABS.
We can ask I'll ask Nathan or baka sila Mariano Palermo. Tingnan natin. About it.
Yung may experience din na centers who have experience with outpatient na bariatric. Kasi I think important yan.
Ang maraming experience ng mga OPD, kila Camilo. Si Camilo yung pinamaraming nag-outpatient na.
Galing nung balong insertion niya.
Galing ka.
Walang endoscopy.
Kasi ganda ng lecture nila.
Pwede pala yun, no? Walang endoscopy.
Interesting.
Buti hindi nagsalita si Ray.
Ano?
Ray, parang may nag-mention yung isang IM na yung complications ng sleeve, mahirap i-manage yung leak. Panis kay Ray yun eh.
Kayang-kaya ni Ray yun.
Panis ni Ray yun. May leak sa sleeve.
Di ba, Ray?
May gas tent lang yun.
Oh, kita mo.
May gas tent lang. Pag may butas, lalagyan pa ng sa loob.
Pag may butas, i-endoscopy. Pag nag-erode yung band, pasa kay Ray.
Happy ka, Ray? Happy ka?
Nice one.
Good session.
Ang lang is, I think yung problema sa Philippines is really educating yung nasa DOH. You can start with that. Educate yung nasa DOH. Kasi pinapahirapan pati pagpasok ng mga gamit. Wala, hirap.
Maraming aspect na kailangan i-cover, kuya, talaga. Para i-promote ang metabolic and bariatric, no?
And how to sell bariatric surgery. Pag sinel mo yung bariatric surgery in a different way, maybe you can sell it. Like, pag pumayat ka, lalaki tingnan yung edit mo. Yun, maraming maghahanan. Maraming magpapa-opera dun. Pag pumayat ka, mas malaki tingnan yung edit mo.
Pag-shave ka na lang, lalaki na.
Sorry, Michelle. Pero totoo yun. It depends on how you sell it.
Kung sinave mo, okay na yun.
I think
diba, parang Omi?
Paano mo sinave?
Hindi na naka-record to, no?
Naka-record.
I think we're still live on YouTube.
Sorry.
Natin able to convince your patients. Kasi si IQ,